Manian. I'm a senior program officer with the Bill and Melinda Gates Foundation, and I will be your moderator today. We have a packed agenda, so I won't spend too much time here. Just a few housekeeping rules. We will have a lot of presentations, so please know that we'll send everyone the presentations after the session closes. So don't feel like you need to take down all the notes on the slides. We'll definitely send them to you. As I mentioned, please pick up a translation device at the end if you haven't, at the back end of the table. And then with that, I may hand it over to Supriya to start us off with some introductory remarks. Supriya, so that you know, we have, I think, everyone online and few people getting settled in the room, but I think it's okay for you to go ahead and get started. Thank you.
Great. Thanks, Savita. Good morning to everyone in the room in Bogota, and good morning to good day to everyone online. As Savita said, I'm Supriya Madhavan. I'm a senior health specialist at the World Bank and at the Global Financing Facility. And we're so happy to welcome you to the satellite session, which must be one of the first of the symposium this week. So really happy to see you bright and early here. So why service delivery redesign? What's all the buzz about? So I think we've seen growing interest in SDR, for short. We've seen growing interest in SDR ever since the 2018 Lancet Commission report on high quality health systems. I don't know if Margaret is in the room, but Margaret Crook chaired that commission, and that report really called out service delivery redesign as one of the big buys to see transformative systems change at a macro level. So I think since then, the World Bank, the Gates Foundation, the Global Financing Facility, and others have really sort of seen this as a tremendous opportunity to support countries in especially pulling out of the COVID pandemic globally, to support countries in rethinking how they might build more resilient health systems, particularly to be able to face the next global pandemic, but really to try to squeeze better outcomes out of their health systems for increasingly constrained resource envelopes. So this SDR really points to the need to right-size. What do I mean by right-sizing a health system? Really deliver the right care at the right time and at the right level of the health system. So really looking at doing that deliberately and intentionally with a few sort of immovable principles in mind. So really to look at health systems that are going to be much more responsive to the needs of their users. So really looking at what families, what women, what communities want from their health systems, how they view quality, and where they want to access care from. Both primary care as well as more complex care like comprehensive emergency obstetric care. So and that's really coming out of COVID, especially to looking at being client focused in a way that really engenders more trust in the health system and more accountability. A second principle is that quality, really drilling down on quality of care and quality of the health systems, is really paramount to seeing better health outcomes. And we really want to help governments and countries deliver on their commitments to delivering higher quality care. We of course need to, in this constrained fiscal space now, we really want to make sure that health systems are more efficient, at doing better, performing better, and delivering better health outcomes with the resource envelopes that we have at hand. And finally, equity as an immovable principle. So we don't want to just see these client-centered systems and high-quality care with more efficiency for certain segments of the population, as an attempt to help countries realize UHC. It really has to be for everybody, for all segments of the population. So the equity piece is really critical. So we have as Savita said, we have a packed agenda today, but we really hope that it's going to be interactive. We've built in a lot of time for questions, for discussion, and we really want to hear from everybody online. I see we have over 60 participants and everybody in the room. We're going to start with my colleague Sanam Roder-Dewan is going to do an overview of service delivery redesign. So going over the definition that we've sort of converged upon now, and really looking at making the case for redesign. Why redesign? What's the rationale behind it? After that, we'll have a research panel really looking at tools and methods that we are now looking to deploy in countries to both do in-depth formative research as well as evaluative research of SDR. After that, we'll talk to some of the implementers from South America and from Africa, looking at what the experiences have been on the ground of really rolling out SDR in practice. And finally, we'll end with more of a conversation, but a panel of folks that can really address the political economy of service delivery redesign. What are the incentives to advance redesign? What does the financing of redesign look like? But to get at those hard to answer questions, so we'll have that panel to finish off the day with. So. Without any further delay, I'm going to hand it back to Savita. Once again, welcome to everyone, and we hope you'll be able to stay with us for the next 4 hours or so. Thank you.
Great. Great. Thanks, Supriya. And so Sanam. I'll introduce Sanam just once again. Sanam Roder-Dewan, please come. She's a senior health specialist at the World Bank, and she'll be giving us sort of an overview around SDR.
Thanks, Savita. So welcome, everyone. It's a total privilege to be here and share with you some of the work that many people have contributed to over the last 5 years. I only have 20 minutes, and my goal is to try to walk through the rationale of, is this my clicker? Yes. The rationale for service delivery redesign, some updates on how we've been implementing redesign, and some examples. And a lot of these are just touch points. You'll hear more from colleagues throughout the morning. So, need to use this mic? I do, huh? Okay. So that's the agenda. So as Savita said, the idea of service delivery redesign came from the Lancet Global Health Commission on High Quality Health Systems, and we have some of our commissioners in the room, looking at Ezekiel over there. And specifically from the recommendation that improving quality will require system-wide action, that we need more than interventions in facilities, and we need to start thinking at the higher level of the health system. It also came from some observational work we did on what is being improved and how improvement is happening, what the targets of improvement programs are currently. And what we found is that more than or about 3/4 of improvement strategies, this one is focused on PHC, targeted the facility level, individual users, or the behavior of providers. And that a very small percent, about 3%, targeted the sort of subnational or district health system, kind of the meso level of the health system. And only about a quarter targeted larger structures within the health system, like how healthcare is financed or how providers are educated. We also found, unfortunately, this is work by Alex Rowe and colleagues, that the improvement strategies at that sort of micro level of the health system have small effect sizes or moderate at best. So these are the most common strategies that we use to improve quality, and their effect sizes are kind of in the range of 10%. So here you see, for training programs, which is the most common approach to improving quality, about a 10 percentage point increase in performance of providers. And so the conclusion was that we need to do things a little bit differently. We need to expand the space around what we consider quality improvement. And we need to move from these micro level, facility level approaches to macro level, systems level approaches that target the foundations of a health system. So 4 recommendations came from that commission work on improving quality. The first was around governance. I'm going to go through these quickly because we'll focus on the last. The second was around pre-service education. So shifting the focus of improvement around provider education to the pre-service arena. The third was around demand for quality and really thinking about people's demand and their preferences as a tool and an approach to putting pressure on a health system to deliver the services that people deserve. And the fourth was service delivery redesign. So also, as Savita said, it's taken some time, but we're sort of coalescing around a definition, which interestingly enough is very similar to the definition that we put in the commission report for service delivery redesign. So I'm mostly a qualitative researcher, and this worked for me, kind of going back and forth between the experience, iteratively between the experience of implementing and working on redesign and the theory that we have around redesign. And so this is our working definition. Service delivery redesign is the intentional reorganization of a health system to improve quality and outcomes. So reorganization could be where services are delivered, when they're delivered, or by whom. So in this table here, I'm just going to give you 2 examples of improve or programs and talk you through why they do or don't meet the criteria of service delivery redesign. The first is centralizing birth, as has been done in places like Kerala State, where over decades, the state has slowly moved the location of birth to primarily hospitals. So most women in Kerala now are delivering in a facility and in a facility that has emergency obstetric and newborn services. So that program definitely meets the criteria of reorganization, right? They moved the place of birth. It was definitely at the systems level. The entire health system changed, and the goal was to improve quality and outcomes. It wouldn't meet our criteria only because this is a multi-decade effort that Kerala State undertook using many different sectors and programs to achieve. So we would say this is an important place for us to learn from, but we wouldn't call it service delivery redesign. Another example is networks of care, which has become a popular, interesting approach in health systems recently. Networks of care are intentional efforts to reorganize the way that systems are working. So connecting facilities where perhaps they weren't connected. Definitely working at the systems level, often at the meso level of a health system, but not always targeted at quality and outcomes, right? So many networks of care are being designed to improve the efficiency of a health system. So we would say that is actually not service delivery redesign. So I hope this was helpful. There's often confusion around the definition of service delivery redesign. Oh, and one little note here, it's not a model of care. Service delivery redesign is not one model. It's a process that we're learning and developing over the years. So just keep that in mind as we talk. So in our experience over the last 5 years, there are sort of 2 clear areas, at least from the World Bank perspective, where governments and our country teams have come to us and said, we're interested in service delivery redesign. We're interested because we have these stubborn maternal and newborn mortality rates, and we need a new approach, a disruptive way of dealing with these rates. So that's one arena. The other is countries that are saying we are heading into an epidemiologic transition, our NCD rates are out of control, we need a PHC system that works. Can we apply service delivery redesign principles to our work? So let me focus a little bit on maternal and newborn health. And I'm moving very quickly because I'm afraid of Dr. Kojo Nimako. So the basis of the maternal and newborn health service delivery redesign agenda is fundamentally about disparities in maternal and newborn health. Being born in East Africa changes your chances of surviving birth as a mother or a baby. Being born in the United States improves your chances and that is fundamentally unjust. And that is the foundation of all of the principles of service delivery redesign, is that this is not a just situation and work needs to be done at a large scale to rectify this. It also comes from the observation that in many countries, maternal and newborn mortality rates are stagnating. So this happens to be data from Tanzania, but we see these kinds of charts for many, especially low-income countries. And here on the left, you see the maternal mortality rates that are essentially, the same since 2000 to 2016. And here we see under 5 mortality rates. Nice progress in the under 5 mortality rates, right? But if you look at neonatal mortality, a much, much flatter line. What we also see is that people are going to facilities, right? Governments have told women and families, you need to give birth in a facility, and people are listening. So what these graphs show you are only countries that have achieved 80 or 90% skilled birth attendance, right? So all of these countries are the same in that women are delivering with a quote skilled birth attendant. On the left, however, we see neonatal mortality on the y-axis varies significantly between these countries. So with the same access to skilled birth attendants, we see mortality rates that are below the SDG target of 12, and we see mortality rates that are far above. So there's a disconnect here between facility birth and your outcomes. For maternal mortality, we see the same pattern. Same access to skilled birth attendants, not the same outcomes when it comes to mortality. And so what we're finding is that it's not access to care that'll make the difference. It's access to the right care in the right place by the right provider with the right team. It's a tall order, but that is actually what will make a difference for maternal and newborn mortality. This is a study from Sabine Gabrish from Ghana, where what they did is they looked at about 120 pregnancies and basically found no relationship between a variety of different outcomes. So for example, perinatal mortality, stillbirth, and distance to a facility. So it didn't matter if you were right next to a facility or 100 miles away. That facility was not providing the care that you needed to survive. They did start finding patterns and associations when they looked at only facilities that provided comprehensive emergency obstetric care or ones that could provide satisfactory competence, provider competence to care, or high quality essential newborn care. This is a study from Margaret, who I don't think is here yet, that shows the relationship between delivery volume and quality. And you'll see 2 patterns here. One, the blue dots are primary care facilities and the red dots are secondary care facilities. So as your annual delivery volume increases, you see improvements in the ability of these facilities to meet quality standards. You also see a clear pattern that these primary care facilities are unable to meet the standards of quality when it comes to childbirth, and that your secondary facilities are in general doing a much better job. Despite these patterns, we still see that in low and middle income countries, a large portion of women are delivering in primary care facilities who are not delivering comprehensive emergency obstetric and newborn care. So here in orange, you'll see home delivery, yellow is primary care delivery, and blue is hospital delivery. So here in sub-Saharan Africa, we have increases in hospital delivery. We have decreases in home delivery, but we have an increasing population of women who are delivering in these primary care facilities that to date, we don't have evidence to show that they're actually making a difference with outcomes. Similar pattern in India with a really impressive increase or decrease in home delivery rates and a large increase in the percent of women who are delivering in primary care facilities. And of course, this stands in stark contrast to the United States, where I practice, and Western Europe, where really the vast majority of women are delivering either in a hospital, perhaps at home, but with very close connections to that comprehensive emergency care. And what it looks like ultimately is that in a country like Comoros, you can go to a health facility and they'll show you this room and they'll say this is the delivery suite. And when you go to the United States, which of course is not perfect, they'll show you the delivery room and it looks something like this. So what is there to be done? There are sort of four basic solutions that we, 5 more minutes? Oh, okay. There are 5 solutions that people respond when we say, okay, we need to do something differently. The first is, well, let's make primary care delivery higher quality, right? The second is, let's do a better job of identifying women who are going to deliver, to have a complication at delivery. The third is, let's do a better job of referring women. So they deliver at lower level facilities, but they get referred if a complication arises. And the fourth, of course, is service delivery redesign. The first has been tested. This is probably the most beautiful implementation study, in my opinion, that's ever been implemented. Massive, 160,000 women in India were studied, delivering in primary care facilities primarily. They used a checklist. They were able to show impressive improvements in adherence to the checklist. So process quality improved. They showed absolutely no difference in mortality outcomes. And one thing to note here is that the C-section rate across all of these facilities was less than 1%, which we know is far below what anybody recommends for needed C-sections. So these deliveries were not happening at the right level of the health system. When women needed a C-section, it appears that they were not getting them. Improving risk stratification. What we're finding from high income settings, but also now from India with a new study that Michael will talk about a little bit more, is that even with really high quality risk stratification, about 30% of women who are low risk prenatally will still go on to deliver a complication. So if you're designing your system so that 30% of women are delivering in a facility that might be 4 hours away from an operating room, you're willing to take on that level of risk for your population, which we're essentially saying is not acceptable. Referral, I think we all know, is incredibly complicated. And when your distances are large, even with a great ambulance system, bleeding across a bumpy road is not ideal clinically. And then fourth is service delivery redesign, where we're looking at the structure of our system and thinking about where services are delivered and is this the optimal location for that service. For primary care, this is actually less controversial, right? What we're saying is that primary care services, NCDs, chronic disease management, those are things that can really well be taken and should be taken care of in communities, right? I'm a primary care physician. I want to be able to see my patients regularly. I want to know what their homes are like. I want to understand their communities. Primary care is very well done, pushed down to the community level for routine care. But for maternal and newborn health services, it's much more controversial because essentially what we're saying is evidence, the clinical understanding of what's needed during this time is that all women need to have access to emergency obstetric and newborn care within about 30 minutes of birth. Again, a very tall order, very difficult, not going to happen overnight, but this is the reality of what the evidence is showing us. I'm going to fly through this. This is our process that we've come to at the bank and also at the Quest Center, is that there are stages to service delivery redesign that take years to implement. There's an engagement process that takes, in our experience, it's been 2 years with many places to understand whether or not service delivery redesign is a fit, whether there's interest from a government. 2 is a formative assessment phase where we're trying to understand feasibility, we're trying to understand quality, we're trying to understand what women and families actually want, what the preferences are within the health system. The 3rd is a design and planning phase, which is participatory with governments, but also with women in communities and district health leaders and stakeholders across sectors. 4th is implementation, and 5th is process and impact evaluation. So I think I'm going to go through these rather quickly, these 5 phases, talk a little bit about implementation. Implementation for maternal and newborn health service delivery redesign requires interventions across at least 5 areas. First is we haven't come across a setting where the hospital level services are of high enough quality to even consider increasing volumes and increasing the number of women that are delivering there. And what we know is if we overcrowd hospitals, quality will go down and women will be treated disrespectfully. And so lots of work needs to be done on the supply side. And that's actually true for primary care also. Our primary care systems often are lacking. Antenatal care is not picking up even simple things like twins in prenatal care. Demand, so that comes after you've got your supply side in order, right? You don't want women coming to a facility that's not ready, but lots of work to actually have people understand, why are we suggesting you go to a further facility? Why are we burdening your family with this additional stressor, right? Lots of work needs to be done here. Access interventions. Without these, service delivery redesign will lead to more disparities, right? Because the most remote, the most vulnerable, the poorest women, your adolescents, those are going to have the hardest time making the additional push to get to a further facility. And then of course, policies and guidelines. These are not yet aligned with service delivery redesign in any setting that we're working in. Okay, so flying through these, I wanted to share some examples. You'll hear more about these, but in Kenya, so you'll hear from Sati and others about the service delivery redesign pilot that's occurring in Kevin, I think online, and Margaret. So this is a very important pilot study in Kakamega County. This is our first formal effort to assess the impact of service delivery redesign. The model that the government in Kakamega County has elected to use focuses on their district hospitals, or they call them regional hospitals, Sati, right? Sub-county hospitals, thank you. So their model is that they would like to increase the number of women, all women, no matter their prenatal risk, delivering in these hospitals, right? So the years of piloting is essentially focused on increasing the number of women who are delivering here. In Megalia, which Michael will talk a little bit more about, the government is thinking about a model that uses CMONC facilities, yes, the first referral, the units here, as their hubs, but they're interested in expanding high volume subcenters that are within 30 minutes of that hub as midwifery-led units. So they're expanding their capacity to deliver the services that they need. And they are using risk stratification so that really the vast majority of women are accessing lower level services, but they're still within about 30 minutes of that emergency obstetric care that they need. So that's a second model that is in development. And then this is a decades-long program in Kigoma in Tanzania, where the approach to redesign was to actually turn lower level facilities, health centers, into small CMONC facilities. So what they have is operating rooms and access to blood in lower level facilities, and they're expanding access to care in that way. And they've actually showed some pretty impressive outcomes in Kigoma County. So again, not a model of care, a process that requires engagement, political will, implementation research, lots of participation from people across the sector, patience, and evaluation to understand the impacts of the work that we're doing across different contexts. Wow, I really flew through that. Thank you.
Great. I think we have about 10 to 15 minutes for questions. So maybe we'll start with the room, and then Kojo, you can see if anyone online is asking questions. So if you wouldn't mind introducing yourself.
I'm Sailesh Mohan from the Public Health Foundation of India, Delhi. So I had a question. You seem to have presented a lot of experience from different countries on SDR. So I was wondering, previously, governments used to say we need to strengthen primary care and have more deliveries at the primary care level. So against that background, how is this new paradigm or paradigm shift being looked at by governments or policymakers? Now we are putting forth the idea of moving deliveries up rather than down. So what has been, in your experience, working with different countries and governments and systems, the perspectives of the government, the ministries, and the policymakers, as well as the healthcare providers?
Any other questions? Yeah. Oh, sorry. I'll go ahead and then we'll.
Good morning, I'm Oscar Bernal, working with the University of Andes in Colombia and with the World Bank. My question is related to centralizing hospitals, but the hospitals tend to do more interventions. In the case of Colombia, at this point, 43% of the women, the pregnant, end in C-section. So it's compared with the 1% you show in India, we have this problem that once the women arrive in the hospital, the tendency of do C-section is very, very high.
Hi, this is Shubham. Hi, I work with Sambodhi Research, New Delhi, India, and primarily we engage in evaluation and monitoring of different public health strategies and projects. So I want to ask you something from the measurement side of the service delivery redesign work, because in our experience there are very little or little information and literature on the measurement framework, even for the health system strengthening approach of different kind of models, like a control law model or a different design models. Now with a new perspective on service delivery redesign, how do you think that, and in your experience, are there measures, are there discussions at a national level or a sub-national level or a policy level to think about how better to assess the process of service delivery redesign? Because essentially it's going to be important to understand how better it's going to be integrating with different model of care that's already existed in different countries. Thank you.
Hi, this is Megan Kumar from the London School of Hygiene Tropical Medicine based in Nairobi. I have two questions. So the first one is, you focus a lot, rightly so, in mortality reduction on technical quality. And how and when do you see bringing in experience of care in this process? So where does that fit in? And secondly, is there a risk of cost shifting from the health system to women and families to get access to these services? Thanks.
Great questions. Thank you. Every government has responded to service delivery redesign in a different way. So in India, for example, where comprehensive primary healthcare is a major focus of the government, some states have been very uncomfortable with this idea and are not interested. And when I say that, during the engagement and preparation process, we're working with governments to identify who's interested, what I mean is that some states are not interested, and we're not trying to get political buy-in. We're looking for political will and interest. There are, however, states who understand that service delivery redesign is not in direct conflict with primary healthcare in any way. What it's saying, for childbirth at least, is that certain services across the RMN-CH spectrum should be done in ambulatory care facilities and are best done in that setting, and some aren't. So Meghalaya state, for example, has really understood this and does not see a conflict between increasing access to its CHCs specifically in Meghalaya and the expansion of primary healthcare in some of its lower level facilities. But it's been hugely variable, and we definitely have governments say, no, we're focusing on primary healthcare. This is not primary healthcare, and we're not interested. The risk of over-medicalization. Hi, how are you, by the way? The risk of over-medicalization and increasing C-section rates. We have many examples, not just Colombia, Brazil, Kerala state, where the C-section rates are going through the roof because of an increase in hospital birth. So I put up the Kakamega model here because this is one of the big risks that a model like Kakamega will need to deal with and will need to monitor for. It's also one of the reasons why, for example, Megalia is interested in expanding access to midwifery-led services, because we know if a birth happens in the hands of someone who does not have a surgical knife, they're less likely to end up with, with a C-section. And that does come to your measurement question, where the routine measurement systems are often not able to capture these kinds of risks. And so, for example, again, in India, the federal level program that the World Bank is starting now includes a strong focus on measures and improving the monitoring of the primary healthcare system in general. And we see that as going hand in hand with any service delivery redesign process, because there are serious risks. So not just C-sections, but equity, disrespectful care, and we need that information promptly so that we can respond to it. But I would say measures of utilization are critical. So where fundamentally are people giving birth? And that's one of the easier things that we can measure. Quality, except quality processes. And this gets, Megan, to your question. Making sure that we're not just measuring numbers of stethoscopes, but we actually understand what's happening to women and families when they're with providers. And then the third major area of measurement is equity. So understanding who you're leaving behind in this process. So Megan, to your question, we are very excited by the work of people like Patience Afulani, who have developed validated measures of experiences of care that we can use in our programming. And we consider that as part of the key sort of monitoring process. So not just technical quality, are you doing the right things, but are people having a good experience in the process. And then the cost shifting, this is why and this has been a hard one. This is why, one of our 5 core sort of implementation areas is around access to care and shifting the way that health systems think about access. Right now, access is really the responsibility of people in most cases, right? And our service delivery redesign programming is very intentionally saying, no, getting people to facilities is part of the work of the health system, right? If you're leaving behind large swaths of people, then you've actually failed in delivering high quality care. But this can't be just about ambulances. It needs to be more creative, because not every woman needs an ambulance, and ambulances are expensive. So exploring things like, vouchers for public transportation for women who are not yet in labor, shuttle services, maternity waiting homes, I think, are a really big, important one that we don't yet understand how to implement well. But it's been a tough one. And if we're not careful, what we will see is that poor women are either not coming, or the cost burden, as you said, is increasing.
If we may interject, we have a question here online.
Oh, we'll take one question and then we have some questions online.
Thank you.
Good morning. My name is Prabhakaran Dorairaj. I'm from Public Health Foundation of India. I've been just listening to you and reflecting on the task shifting bit. The task shifting has been there for quite some time. I mean, I think the Alma Ata Declaration was the first one to talk about task shifting 45 years back. But the task shifting has been uneven, particularly coming from the chronic diseases background. What we see is the biggest impediment to task shifting is the fear that some of the tasks which are performed by physicians or nurses are taken away and given to community health workers. So we had this problem in India when we were trying to do this for some of our work in hypertension and diabetes. We just changed the terminology to task sharing. Instead, it's in fact, they're sharing your tasks and it's likely to reduce your load. And that kind of narrative helps. So I just wanted to know what your thoughts are on these.
Kojo, do you have questions from online? Inez?
Yes, so if I'll just unmute Same if you want to go ahead and ask your question.
Sure. Do you hear me?
Yes, we do. Can you hear?
Okay. Yes. Okay, Sanam, thank you very much for a very interesting presentation. My name is Samah Al-Saharti. I work as lead health specialist at the World Bank in Washington, D.C. A couple of quick questions. One is, there is also the notion of service delivery optimization. So is there a difference between system delivery, service delivery design, redesign, and service delivery optimization? Second question is, can we do SDR at just one level of service delivery, like, hospital care or tertiary level or primary care, without looking into, the connections between this level and other levels? Thank you.
Okay, thank you, Dr. Prabhakar. Now let's start with your question around task shifting. I love this idea of task sharing, right? Because we do know that teamwork is a key relational component of high quality care and is missing in a lot of places. So I appreciate that clarification. I think task shifting can work really well, and it can also be a slippery slope, right? Often task shifting means taking services from a higher level, more expensive provider to a lower level, less expensive provider. And so I think there's an incentive to try to push as much down as possible. But frankly, I don't think we don't have evidence often that lower level is able to provide care at the quality that's needed. I think in some cases it probably is, and in some cases it isn't. But this sort of carte blanche, let's move services down and make our systems more efficient, I think can run us into quite a bit of problems. On the other hand, what I've been observing in India, for example, is that a lot of services are being delivered by specialists that, as a family physician, I know I can deliver quite well, right? And I would be a cheaper provider for the system than a non-family physician. So I think it's an important area to explore, but it isn't a silver bullet, essentially. And then the question online about levels. I would argue that an effort to improve the functioning of a single facility, it would not be redesign. Even if services are shifting within a hospital, I think we're really focusing on programming that connects facilities and thinks about services across different levels of the health system. I think some people might disagree with me on that, but I do think that the system and multiple facilities are a core piece of service delivery redesign.
Yes, and if there are more questions, we'll have a coffee break, lunch break. So we hope the discussion can continue, but I'm going to move us along. As I talk, I may ask our three speakers to come up in front. So I'll introduce you all at once. We're going to shift a little and talk about sort of current research that's being done around SDR. And so we'll have three presentations. The three presenters will present. I'll ask you to hold your questions, and then we'll have some Q&A at the end. So the first presenter is Michael Peters, and he is a consultant working on service delivery at the World Bank. And he'll talk around analytics that are currently being done in Meghalaya State, I think, for SDR. And then we'll move to Paul Uma, who's a geospatial scientist also at the World Bank, to talk a little bit about some of the analysis he's been doing for SDR in Chad. And then lastly, we'll have Kevin Croak, I think, who'll be joining us virtually, who is an assistant professor of global health at the Harvard School of Public Health. And he'll talk about the evaluation design for SDR that's currently taking place in Kakamega County. So Michael, I'll hand it over to you, and then we'll go through the presentations, and then we'll have a Q&A after.
Thanks very much. My name is Michael, and I am pleased to be here today to talk to you about the role that implementation research plays in the service delivery redesign process, and specifically talk about the experience and applications in projects in India. So the agenda for this talk, in 10 minutes, I will very quickly talk about the relationship between implementation research and service delivery redesign. I'll talk about the context and rationale for SDR in India, and then give some of the early results from a program in Meghalaya state. So as Sanam talked about this morning, service delivery redesign is really a complex intervention, and more than an intervention, it's a very complex process. And so implementation research, or the science of translating what we know works into improved outcomes, plays a key role at actually all of the different stages of the SDR process, all the way from engagement, where we're trying to identify the policies and the opportunities to do service delivery redesign, to the feasibility assessment stage, where we're identifying the contextual factors and the current implementation bottlenecks to delivering high quality services, at the design phase, where evidence needs to be translated into actual programs that will improve the quality of services using stakeholder-led design processes, and then during implementation, because this is a complex process and there are opportunities to iteratively adapt and change the service delivery redesign program. And then finally, during evaluation, understanding what are the generalizable lessons that can apply to other contexts. What was the fidelity of the reform as it was designed? And so what we're doing at the World Bank is, with partners, developing a suite of tools that can help with implementation research at all of these different stages of the SDR process. So from the engagement stage, coming up with some policy mapping to identify opportunities to do SDR. At the assessment phase, Paul will talk a lot about the geospatial analysis, but we also have developed a suite of supply side assessments to understand the level of quality that the health system currently is providing, and what are the kinds of patient reported outcomes that are that could be improved. Also, we're doing some really innovative patient pathway analysis that is trying to describe systematically how people are moving through the health system and why they are choosing to seek care from some sources and bypass in other sources. Also, a key part of this is incorporating the community perspective and the patient perspective, so that what an individual expects from the health system is what is reflected in the redesign. I'll talk a little bit about the SDR planning tool that we've just gone through in Meghalaya, and then we have some very context-specific implementation and evaluation tools that Kevin will also talk about later on. So one place where a lot of these tools are being rolled out in different contexts is in India. So it's a great place to kind of give examples of how these are being applied in different contexts. So India has made great strides in improving population health over the last couple of decades. A woman born today is expected to live 12 years longer than she would if she was born in 1990. And there have been large reductions in infant mortality and huge improvements of coverage for key services, but some key challenges remain. So for example, there are persistent pockets of high infant and maternal mortality, and the rising burden of non-communicable diseases that we talked about earlier is really needs to be addressed. And then finally, high out-of-pocket expenditure and health financing is a problem that is also persistent. So this is some of the findings from a study that was requested by colleagues in the Ministry of in the Indian government, done with Margaret and also other colleagues, where we found that almost half of neonatal deaths occur among low-risk pregnancies. So using NFHS data, we tried to stratify pregnancies as high risk and low risk, and we found that there's really no great way of identifying who needs to be delivering in CMUNC facility, or near a CMUNC facility. So this really drives home Sanam's point that all women need to be delivering within 30 minutes of a facility that can provide comprehensive CMUNC services if we are to drive down neonatal mortality. At the same time, India has a huge burden of and rising burden of non-communicable diseases. So the system needs to be redesigned or reconfigured to provide care to the over 190 million people living in India with uncontrolled hypertension and other millions with uncontrolled diabetes. So service delivery redesign, you saw this slide from Sanam. There are some contextual factors across the country that are playing a huge role in these processes in India. So really what we're talking about here is pushing up those high acuity conditions to tertiary services, so delivery, and pushing down those low acuity conditions, so non-communicable diseases, to the primary care level. These are some of the contextual factors that are specific to India, are the fact that there are so many different kinds of providers, and the market for who is providing care is so diverse. You have private formal sector, you have private informal sector, Ayush and alternative systems of medicine. So working with all of these providers to redesign care and the level that service is provided is really difficult. Also, the fact that health is a state subject, there's a lot of cross-state variation and even within state variation about the kinds of schemes and the kinds of programs that are providing care to people. And so health and yeah, also the context-specific vulnerabilities and power dynamics that come into play. So these are a lot of the overall factors. The World Bank is doing is in different stages of the SDR process in 6 states in India. So just to give an example of the kinds of priority issues that are being solved or addressed with SDR, in Assam, the SDR is really aimed at reducing high IMR and MMR in key populations, so specifically tea estate populations and riverine populations. In Gujarat, which is a little bit more advanced, we're looking at really applying SDR to improve NCD care and address some key issues like reducing anemia in adolescent girls. In Meghalaya and Mizoram, SDR is trying to improve services for vulnerable mothers and newborns. And then in Odisha and Uttar Pradesh, the SDR reform is really aimed at strengthening comprehensive primary care. So the suite of tools have been rolled out in different states according to the different issues that SDR is trying to address. And I'll talk a little bit more now about Meghalaya, where we're a little bit furthest along in the process. So a little bit of context: Meghalaya is a state in Northeast India, population of about 2.6 million. It's unique in India because nearly 80% of care is sought from the public sector, but there are huge accessibility challenges. So flooding, it's very mountainous, and there's not great road connectivity, makes a challenge for access to high quality services. And this is reflected in the fact that IMR is still high across the state. So it's about 20% higher than the national average in India. And then over 40% of deliveries are occurring at home. So there are some serious access challenges and quality challenges that SDR is trying to address in the state. So we have some of the recent findings from, or initial findings from the feasibility assessments that was done by our colleagues at Oxford Policy Management. And what we've found is that generally access to CMUNC facilities is low across the state. But interestingly, when providers were interviewed, some of the districts were definitely overworked, but some of the providers in certain districts, such as the West Jaintia Hills, were reporting that they actually had the capacity to see more patients. So this is an opportunity where we could actually reshift where people were seeking care at the health center. And this actually had a knock-on effect of low volume, where health providers were not seeing sufficient volume to ensure that their skills were maintained and they were able to provide quality at a high level. And this was actually reinforced by another part of the feasibility assessment, where we found that provider competence and the ability of providers to provide high quality care was actually lacking, and there were huge opportunities to improve that competence. And then also at the same time, CHCs, community health centers, were missing a lot of the key infrastructure needed to provide high quality CMUNC care. So moving from this overall assessment, we realized that, or the next stage in the process was to prioritize and understand how to translate this into a program at the district level. So this is an example that Sanam was talking more about, where we through a stakeholder-led process with district health officials, presented this evidence and basically talked about what were the options that might work in a very localized context. And so this is that West Jaintia Hills, the district health team that we were talking about, and they really identified the hub and spoke model that Sanan mentioned, where they wanted to try and risk stratify, but make sure that even women who were or pregnancies that are identified as low risk were delivered in high quality midwifery-led centers that could then be easily referred up to FRUs should complications arise. And so this is really what SDR looks like on the ground, is translating that evidence, using implementation research to translate evidence into an actual design of a program. And so what that actually looks like in practice is that 3 facilities were prioritized to upgrade to hub CMONC centers at the CHC level. 4 sub-centers were identified and for upgrading to operate as spokes that would expand access in the referral pathways. And then the human resource capacity gaps were identified and were actually using the policy identification tool. We actually found that they could request these specialists that were needed to provide high quality CMONC care through existing state initiatives. So we're actually leaving from this workshop to go back to Meghalaya and work on translating this plan into an actual program that will be described and implemented. So we're really excited that implementation research is informing these SDR projects across the country. And we're excited about the suite of tools that's being adapted to help the process in other contexts. We're also really excited about the growing community of practice. So Oxford Policy Management, and we are very pleased to have our colleagues from Sambodi who are going to be doing the feasibility assessment in Gujarat. So we're really growing a community of practice that is joining the SDR principles. And then finally, by describing these processes and models in a systematic way, we can hope that the lessons learned and the findings can be applicable in other contexts and can be helped to make these reforms more effective in other places. Thank you.
Okay. Morning, everyone. Yeah. Happy to be here also. I will take you through the presentation on how we are using geospatial methods and geospatial tools to inform assessments on where we need to improve various services. And for this one, I'm giving an example of Chad, which is a country that we have done quite a lot of work on. And we've seen this slide already, just showing that this is a country that has some of the worst indicators of maternal and newborn mortality globally. And projections also indicate that based on the current trends, the country is likely to miss most of the SDGs and in terms of maternal mortality and also neonatal mortality. And so what we are trying to do is to understand, using geospatial tools, where can we see the different variations in terms of access to facilities. And if we think of SDR, if we want to, for example, look at ensuring access to CMONC services, then what is the current level of access to these services in the country? And where can we try and improve the service availability? Of course, this is not just service availability, but also ensuring that we ensure access to quality CMONC services. And so geospatial tools have been used for quite a long time to do such kinds of analysis, where we assemble different data sets that can be used to inform how mothers are likely to use these facilities. And so we had different objectives, 3 main objectives. And the first one was for us to map out all the facilities in the country, and then also segment those ones that provide CMONC services. Then we were going to use these facilities in addition to other physical features for us to determine geographic accessibility. Essentially, we wanted to estimate how long it would take for a mother to get to the nearest CMONC facility based on their residential location. And then accessibility has been defined using different metrics, but the WHO recommends mothers living at least 2 hours from the nearest CMONC facility. But one of the things that we're also trying to do is to test this 2-hour metric and to see how feasible it is for us to use that metric. Then after that, we aimed to extract population level metrics of accessibility. And here the main aim was to come up with at regional level, what is the variation in terms of geospatial accessibility? And then we were using data on facility births and those mothers who actually used cesarean sections for us to tailor make and to understand better the catchment areas of these CMONC facilities. And the first thing that we did was to understand the level of health service delivery in the country. We have close to 2,000 facilities that, as you can see, are distributed across the different regions. And as per the health sector strategic plan, is that each district should have at least a district hospital. And theoretically, what the country is saying is that they have 131 district hospitals with 23 regional hospitals, which we expect should be providing CMONC services. But when the assessment was done, the results were shocking that only 69 facilities were providing CMONC services. And we haven't even gotten to the quality of these services. And as you can see, this is the distribution of these facilities that provide this crucial service. Of importance is that only 44, that is about 30% of the district hospitals provide this crucial service. And already we can see the areas that we need to start focusing on if we are to improve services in the country. But also we have provincial hospitals that actually cannot provide CMONC services, which again was also a shocking outcome. But again, we used all this information on the location of facilities, additional factors such as the road network, protected areas, and location of mothers who would need these services. And then in addition to that, regional workshops were done in the country for us to understand exactly how do mothers access these services, what are the transport modes that are used, what are the speeds, and then we were able to plug this into a model for us to be able to estimate for each location in the country how much time they would take to get to the nearest facility. These are some of the results at regional level. As you can see, the accessibility quotients were high for densely populated regions such as Jamena, but other regions in the northern region of the country, you can see that accessibility is actually quite poor. Less than 20% of the mothers living within 2 hours of a CMONC facility. But also what we did was now to compare based on the 2015 DHS data on attendance to facilities and the mothers who actually delivered by CS, and to see how this one relates to the travel time metrics that we had generated. And as you can see, this graph just shows you that there is actually a distance decay from those who are much closer to the facility, and as the travel time increases, then the cesarean section rate also reduces. Of importance is also that even for those mothers who are living quite close to CMONC facilities, they are still, most of them are still not using the facility, maybe as they should be, because we know the rate should be at least 10% at the population level. I know the value normally differs, but at least 10 to 16% is the recommendation. But as you can see, even areas which are quite closer to the CMONC facility still have quite lower rates of about 4%, which again just shows you how there are other factors that might be affecting the use of this service. Again, something that we got here is that we can't rely on the 2-hour metric that is recommended. As we can see, the cesarean section rate starts to reduce quite significantly even before we get to the 2-hour threshold. And we might need to start rethinking how we implement such a threshold in defining geographic accessibility. And perhaps this maybe is different across different settings, and maybe for other areas we might see that 2-hour being replicated. In addition to that, we were not just looking at physical distance or travel time, we're also looking at other factors. As we know, poverty is something that can affect the use of facilities, and we mapped out poverty rates within the country using, again, geospatial tools. So we obtained poverty data at cluster level from the recently done demographic and health survey. And as we can see, the areas in red are actually areas which have poor outcomes in terms of poverty. And then we can combine that information in addition to the information on proximity for us to be able to tailor make our decisions. For example, we have areas which have poor accessibility, but then also the poverty is poor. We might need to start looking at them differently from those areas where accessibility is poor, but the poverty rates are quite low. And so the table just gives you the different variations that you can think about if we are going to tailor make decisions on how to improve accessibility to CMONC services. Sorry about that, but the discussion is that, sorry. Yeah, the discussion is that geospatial tools can be really useful. We've not just done this for Chad. We have done it for quite a number of countries and settings. And the decisions on where we need to improve services, of course, depends on the setting. And we are tailor-making the analytics depending on the setting that you are working on. Thank you.
I think, Kevin, you're on next for the last presentation.
Thanks, Evita. Let me just try to share my screen here. You can tell me if you can see it well. Can you all see my screen?
Yes.
Yes.
Great. You can hear me okay, I hope?
Yes.
Just go slideshow. Okay, you can still see the screen well? Great. Okay, so nice to be connecting virtually, and I wished I was with you all in Bogota, but I'm glad to be able to connect virtually. So I'm going to talk about the evaluation of a particular SDR for maternal and newborn health pilot, and this is the one from Kakamega County in Western Kenya, which Sana mentioned in her slides, and I think you're going to have some presentations on throughout the day. And I'm going to present on behalf of a broader evaluation team, including Professor Margaret Crook, my colleague at Harvard School of Public Health, colleagues from Jacaranda Health, colleagues in the Kakamega County government, and also at Kemri Wellcome Trust. And what I'll try to do in 10 minutes is to talk a little bit about the rationale for doing a comprehensive evaluation of this particular SDR pilot. I'll talk a little bit about the designs and the design challenges which come up in this kind of evaluation, and how we've tried to address those challenges, and then some very preliminary findings from the baseline data, which is the phase that we're in at this point. I'll just start by taking a step back and sort of ask why evaluate. I think Sanam and others have gone through the logical case for thinking SDR makes sense, is a reasonable and maybe even compelling way to address the inequities we see in maternal and newborn health. But I would say it's very well supported by theory, by related evidence, by associational evidence, but it actually hasn't been directly and prospectively evaluated in a real world setting. And so, I think this calls for a rigorous evaluation with a credible design. And there are many different ways to do evaluation, but in this case, I'm going to mostly speak about an evaluation which has a counterfactual, in other words, a control group. And so we're going to think about how a particular model of SDR, in this case in Kakamega, could be evaluated, and in fact is being evaluated in this way. And I think it's really critical, because I think you probably appreciate from the previous presentations that this is really more than a single intervention. It's really a kind of health system reform. It's a complex intervention, and it's intervening on the system. And so both the intervention and the object of the intervention are complex. And so I think it's not a simple biochemical process. We really can't assume that our interventions will have the expected impact on the system. We can't take that for granted. We need to evaluate. And so in a perspective,
Kevin? Oh,
yes.
Sorry to interrupt. Oh, you were in presenter mode. So I don't know if you can switch to presentation mode.
Sorry. So what, are you seeing this better now?
It's still not in presentation mode, sorry.
No worries. How about now?
It's still the same, I think.
I think they don't like the fact that it's.
What about now?
Yes, that's better.
Perfect, thank you.
All right, no worries. 2 years into Zoom, still have these hiccups. Okay, sorry about that. So let me just try to move the. Okay, so in this setting, we, many health system evaluations, many health evaluations, we would ideally like to use as strong a design, as rigorous a design as possible. And in some cases, this means the randomized controlled trial. For this particular evaluation, that was not feasible, but it is possible to use a controlled and non-experimental design. In this case, we use a variant of a difference in difference design. And so we'll be comparing outcomes both before and after the intervention, both in a treatment group, which we can think of as the areas in which SDR is taking place, but then also a control group. And this model respects the complexity of the setting and of the intervention, but it also rests on some, I think, important assumptions. And that's, even as we measure outcomes, our outcomes of interest over time in both a treatment group and a control group, because we're not in an experimental world, we realize these outcomes may be on average different at baseline. But we assume that the trend over time would be roughly comparable and even perhaps parallel in those settings. And so if we see strong deviations from this parallel trend in the treatment group, but the continuation of the pre-existing trend in the control group, then we're going to make inferences about the effect of the program. We're going to assume that the change that we see is due to the effect of the program. And we're going to want to, as we go along, test those assumptions as carefully as we can so that we can hopefully strengthen our confidence in the validity of this design. How do we operationalize this in Kakamega? So the way we sort of accepted a design that we were handed by the county government, or that we understood was the plan of the county government, was that they were quite enthusiastic about SDR. Sana mentioned political will. I think this was the county, which from the very beginning of the discussions in Kenya around SDR had very strong political will to attempt an SDR reform, but they had a specific way in which it would be rolled out. And the specific way was that the reform was going to be challenging to implement across the whole sub-county at once. And so they opted for a phased design. And so you can see in the map here of Kakamega County, the sub-counties in purple are those that are to be implemented in a first phase. There's a lighter blue set of counties for a second phase, and then a green set of counties for a third phase. So there's 12 sub-counties, and they'll be implementing this reform in a phased manner across the counties. And this allows us to prospectively evaluate. So essentially, anytime you have a phased scale up or rollout of a program, it gives you an opportunity for a strong prospective design. And so that's what we set out to do in Kakamega. And the biggest challenge in this kind of design then becomes the nature of the program itself, which is targeting a challenging intervention, challenging outcome to measure, which is maternal and neonatal mortality. And so the way we have done this, I think, the intervention itself, I know was discussed a bit before, but you can think of this as strengthening sub-county hospitals, providing new forms of emergency transport, increasing clinical mentoring for emergency obstetric care, and then once those interventions have taken place, then changing the policy so that women are advised at antenatal care that they should, if at all possible, deliver in a level 4 facility, essentially a CMONC facility, as opposed to delivering in their local PHC clinic. And so to evaluate this in the phased way that I've just described, we have set up a kind of rolling ongoing enrollment process across the whole county, so that we have a baseline period in which we're measuring outcomes across the whole sub-county. And then as different sub-counties begin their implementation of SDR, we'll be able to observe how outcomes change in those counties compared to sub-counties, compared to the other sub-counties, which remain our control settings. And so in 72 facilities across the county, we're enrolling over a 2-year period, all women who attend antenatal care. They're enrolled and their contact information is collected, and then they are recontacted after their expected delivery date, so that information about the outcome of their pregnancy, but also their experience of care, the travel times they faced, the costs they faced, are collected and compared across the SDR and the control communities. And so our primary outcomes are a composite of maternal neonatal mortality and stillbirth. And then the implementation side is also critical. So this, what we call the pregnancy registry, which is this large sample capturing outcomes, is also supplemented with facility and provider surveys, delivery observations, as well as more qualitative data collection focused on implementation processes. So the data collection has been ongoing since February. This is day 1 of data collection. You can see the enumerator. One of the enumerators in one of the lower level PHC, HC level 2. About 18,000 women have been enrolled in the sample at this point, and about 8,000 of them have delivered and have been fully followed up as of last month. We've also done 2 rounds of facility assessments. I think one sort of lesson learned for SDR evaluations is that because the mortality outcomes are statistically rare, not rare enough, but statistically rare, you need quite a large sample, and so you need ways of making data collection cost effective. And so we have done face-to-face surveys supplemented, mobile phone surveys supplemented with face-to-face follow-up. And what we found, if you just look at the top 2 rows here, for our 7-day and 28-day follow-up, we've been able to achieve 96 to 98% follow-up, basically by combining about, so 80% of women have a phone and 99% can give a phone number at which they can be reached at, but only 2/3 can actually be reached at those phone numbers. And so we've done about 2/3 of interviews via mobile phone, and 1/3 have been field teams following up and interviewing those women in person. And so I know I'm just in my last minute or 2 here. So what have we learned so far? I think, the actual implementation has not fully begun, and so we don't have any results per se about the impact of SDR. But I think we've learned a huge amount from the surveys and also administrative data, which can provide an important evolving picture of implementation, very much along the lines of the implementation research that Michael was mentioning. I think the baseline data that we've been collecting also provide a way of testing some of the key assumptions about the SDR theory of change. And I can talk more about those, the ways in which we've been able to probe and test some of those theories with the baseline survey. And then I think the implementation science and qualitative components of the project are also underway. This is the KEMRI team led by Dr. Jacinta Nzega, Benjamin Sofa, and Easter Alwanda. I think this will equally inform project implementation and shine a light on both perceptions, unintended consequences, and also the politics of SDR. So I'll leave it there, and just to mention that I think that the main assumptions of the research design have been validated. The early findings are largely consistent with the theory of change, but one thing we have seen in both the facility surveys as well as qualitative work is that what we can think of as sort of the provider side interventions, so the staffing of specialists in sub-county level hospitals and ensuring adequate supplies of medicines and commodities are something that has shown up in the facility surveys as something that's still some gaps to be filled. But otherwise, we largely find behaviorally many of the findings from the pregnancy survey are in line with the SDR theory of change. I hope we can talk about that more in questions. And I'll just end with thanks to the HSPH, Kakamega, Ipsos, KEMRI, and Jacaranda Health evaluation teams. Thank you.
Great. Thanks, Kevin. Okay, I realize we've had a lot of presentations, so we'll open it up for questions on all three presentations. We'll start here, and then Kojo, you look online, right? Okay, we'll start. I'll give you the first mic.
Thank you for the presentations. I had two questions. One to Michael. Can you elaborate a little more on what actually is the function of the spoke, the subcenter? Is it just conducting good quality antenatal care, uncomplicated deliveries, or risk stratification and referral? So I was not clear what is the renewed mandate under SDR. The question to the other presenter is regarding the very low levels of adherence to the guidelines in terms of comprehensive obstetric, maternal and newborn care, whatever that acronym is. So I found, if I remember correctly, the district hospitals, only 19% were adherent, around 19% were adherent to those guidelines. Why was there such a huge gap? That means that there is really big gap in the system in providing evidence-based MCH care.
Yeah, please go ahead.
Hi, thank you. This is Shubham again. And my question is directed to the other presenters. I was working in the space of health systems and evaluations and learning. While we were discussing about how better to kind of assess service delivery redesign. But what we have faced most of the time that the health systems intervention, by the virtue of being health systems intervention, there is little possibilities of having a counterfactual design. Because most of the time, let's say there's a change in the CMONC structure, or maybe there's a change in the skill training of the CMONC services at let's say FRU, it will be spread across the state until unless it's a very it's a small part of the sub research which is going to scale up. In this scenario, do we have better ways of assessing the service delivery redesign in terms of, let's say, using a more realist evaluation lens, or maybe a multiple case study design, or maybe thinking about a contribution analysis rather than thinking of from a very impact evaluation lens or a attribution lens? Thank you.
Questions, and then we'll.
Hi, my name is Rakesh. I'm also from Sambodhi, Shubham's colleague. So my question is again for all the presenters, it's a little more conceptual level of SDR. So I wanted to ask if in any of our experiences that we presented, have we also kind of included the, say, wider systemic side of the service delivery redesign, such as who pays for redesign services, like what happens to the finances of redesign services, or are we just looking at, say, changing the places of the services and who is delivering the services, vis-a-vis also looking at the wider systemic dimensions of it? So that's
We also have a question online when you're ready. Thank you.
Maybe I'll go ahead. Mainly a question for Michael, although maybe Sanam can also respond. You showed the slide of neonatal death not necessarily being predicted by risk, right? Like low risk infants, where half of low risk infants were actually dying. And then we're looking at this model that's talking about risk stratification. I know there are challenges with risk stratification. What is the conversation like around what we mean by risk stratification and what data points we're looking at?
Okay, why don't we start with this and then we'll come back. I know there's a question online and a few more questions here, but let's start here. Maybe I'll start with Michael, and we'll start folks in the room, and then Kevin will come back to you.
Thanks for these questions. Maybe I'll first start with the first question about the function of the spoke. I think that's a great question. The exact the exact function of these subcenters is still being worked out. I just want to point out one key thing is that it's not the SDR mandate, and this isn't going to look the same in every single district where this is working. This is what will work, or this is what the district health officers in West Jaintia Hills think will work in their specific context. So it's not to say that what is happening in this district is supposed to be applied in all of the subcenters in all of the networks across India, but just for this specific context. And so I think that we're talking about things like ANC, low risk pregnancy. So maybe by increasing the quality of ANC services, hopefully the identification of low risk pregnancies is then improved. But then the key point is that even when those low risk pregnancies are identified, that's within 30 minutes, the delivery are still within 30 minutes, and access to CMONC facilities is still ensured. And so just to talk a little bit about the paper that or the analysis we're looking at, is there were some high risk characteristics of pregnancies that were applied to pregnancies in the United States. We use those same characteristics in India based on what was available in the NFHS. And so I think that if we were doing this operationally, there would be a different set, but we can share that paper and that methodology. I'll just answer what the one other question about financing before passing to Paul. I think Rakesh, we're trying to really focus on the technical approach and proving that this works at a technical level. Right now, the financing is not necessarily the focus of the group that we're working on. There are people at the World Bank, so looking at systems like PMJ, how to change the reimbursement schemes and how to change insurance reimbursement schemes to incentivize women delivering at CMONC facilities. So there are groups that are working on that, but that's not necessarily what we've focused on yet, but definitely an area for expansion in the future. Thanks.
Yeah, I'll respond to the question on the gaps that was observed for district hospitals. Yes, but before I just focus on Chad, let me just say that this is a problem that we are seeing in quite a number of countries, where we have facilities, for example, labeled hospitals, but they don't have the necessary infrastructure, human resources that are needed for them to be able to provide some of these crucial services. So it comes down to availability of these factors, necessary doctors or even obstetricians, ability to provide blood transfusion services, or even an operating theater, or even other issues like electricity could affect ability of a facility to provide these services. On whether we need to keep calling these facilities hospitals, I think that's probably a conversation for another day, but it's something that we really need to start thinking about on whether these facilities are actually district hospitals or they are just health centers that have been elevated based on their name. Yeah. Over.
Kevin, do you want to?
Yeah, over to Kevin.
Yeah. Come in.
Sure. So I think the question was about in what sense is it possible to do an evaluation with a counterfactual or a control group when it's a systematic reform which can affect the whole jurisdiction at the same time. I think this is kind of a classic problem with evaluating health system reforms, but I think if you take into account the fact that many reforms which are supposed to affect the whole state or county or province at the same time, actually, when you get into the kind of nitty-gritty of the implementation plan, they actually are phased in many cases because it's hard to implement things at a large scale at once. Usually there is a kind of phasing in over time. And if there's a phasing in, then there's an opportunity for a control group and a counterfactual. So I think in many cases we think it's impossible, but it's actually possible if you really get into the details. But then I think the second question that the audience member asked is does it then make sense to think about realist evaluation or other models? And I think it also does make sense to think about that, in part because so much of the complexity of this kind of reform comes about in the implementation. And I think we will learn a lot in Kakamega by studying the implementation. And so I don't think it's an either or, counterfactual or impact evaluation versus realist or process or implementation evaluation. I think they're really quite complementary. And going back to the first point, we kind of worried in the beginning that maybe things would roll out so quickly in Kakamega that we wouldn't have a counterfactual, and it's actually been the opposite. That it just takes a long time for the kind of machinery of government to get going, and so you end up with probably more time to have a treatment group, and a control group that's not exposed to the program. Thanks.
So I think we'll go online just for a few questions and then we'll come back. So Kojo? Yeah.
Thank you. Roger, would you like to go ahead?
Yes, thank you very much to the presenters. Good to hear that service delivery design has been taken up by a place near the East African region here. I thought that many countries would fear to adopt it just because it's a very huge reform and it takes lots of effort and political economy pain points. So I'm just wondering, Kakamega biting the bullet, what did it have to do in terms of readjusting its health financing framework to really be able to adopt this? I want to believe it's not anything easy to take up. Thank you.
Are there any other questions online?
Shika, would you like to go ahead?
Sure, thank you, Ines. So I specifically had two questions. To Michael, I just wanted to understand if there are any early trends or lessons on how the intervention has fared in terms of specialist provisions in Meghalaya. So how to better engage with specialists. And I'm coming from a background basically where working in the Indian states, we often find that it's difficult to connect specialists, particularly in terms of difficult terrains, be it geographically or economically. They're not very willing to come work in centers which are located in hard to reach regions. So are there any lessons on how better we can engage with specialists? And second, to the other presenters, I just wanted to understand that when we're looking at service delivery redesign from supply demand perspective, are there any focal points that we can approach the demand perspective from a trust building in health system? Because when we're working with vulnerable populations and tribal populations in the Indian context, we are finding that one of the first steps that we first need to establish is the trust building in health system. So when you're talking about a supply demand service delivery redesign, does that factor in, or how do we go ahead? Thanks.
That's all for now. Thank you.
Okay, then we'll take one last question in the room and then we'll.
I think this is working. I'm Prabhakaran Dorairaj, again from India. Part of this question has been asked in terms of, the question is to Kevin, in terms of the counterfactual and the control population that is required. I want to ask a provocative question. In SDR, why do we really require to look at mortality and hard outcomes? Why not look at only process outcomes? Because look at cost effectiveness, reach, access, implementation, maintenance, sustainability, acceptability, quality, and so on and so forth, which are far more important, because the underlying premise in an SDR is that we are ultimately going to improve whatever hard outcomes that we are going to do. Because we're going to make the same mistake as conventional research where we are looking at trials. And if we want to do trials here, we have to look at something like a cluster design, which is more complicated. We have burnt our fingers in that, particularly in the chronic disease space. So I just wanted a little bit of a reflection on that.
Okay, I think we'll turn it over to our panelists to start. We'll start in the room first, Kevin, before coming to you.
Great. Thanks for these questions. Rogers, maybe the first question in order. I think we are going to be hearing from the Kakamega team later in this this session. So I think that they'll be best placed to answer the experience and what the health financing adjustments were needed. So I think that will explicitly come up. As for the second question about specialist provision in Meghalaya, so you're exactly right. That is one of the major gaps in terms of the ability to provide CMONC services at higher level facilities in India, is that there really, I think in the entire state, there were 2 gynecologists. There's just not enough specialists at the CHC facilities. And so what we're actually doing in Meghalaya, which is really exciting, is working with the government, who is already working on a separate plan to increase specialists in the state. So there's an exchange of specialists from Tamil Nadu who will actually go and provide care and will actually be placed in CHCs in Meghalaya. So leveraging on those existing policy actions that are already happening, we're going, the districts have identified their human resources needs and are actually working well within these existing structures to enhance their ability to provide CMONC cares. And then also your second question about the demand side, it's absolutely essential in the SDR process. We talked a lot about the supply side, but a lot of the work that we're doing in terms of trust building and in terms of understanding people's demand for services, there's a lot of qualitative work and community-based work trying to understand why people are bypassing certain facilities, why people, what people want to see out of their health systems and what they want to see out of their care. And that's really a key point that is integrated into this entire process. So yes, that should come out clearly in the work and the design that is ultimately taken up. And I think, Kevin, over to you.
Sure, thank you. So I think the question was a good one. Why go for the hard mortality outcomes? Why can't we just be satisfied with process, acceptability, and so on? I would say kind of 2 reasons that I see. One is that I think SDR is controversial. We should face that straight up. Many countries, many policymakers see it as in some sense, a divergence from PHC, and it costs resources, and so they don't think it's necessarily the right way to go. And I think, as with many controversial reforms or programs, it's important to put them to the test. So a policymaker that says, I think this goes against some other things that I value, does it actually reduce mortality or not? I think it would be easy for them to say, well, if it's not reducing mortality, I don't really care that it's acceptable to everybody. It costs more, it's not delivering health, so why should I do it? So I think it's worth trying to get at these hard outcomes if we can. And I think secondly, just because resources are limited, and if you just think about maternal and newborn mortality more generally, you can think about many, many, many ways you want to intervene. You can think about, adolescent, sexual and reproductive health. You can think about nutrition, and which one should we do, right? At some level, we should do all of them, but we have to go for the ones that have the biggest impact. And I think we can't learn that unless we go for the health outcomes. But I don't think that precludes doing everything else. And so in all of our surveys and also our qualitative work, we've tried to measure every link across the results chain to understand coverage, acceptability, cost, quality, and so on. I think in many ways, those 2 things can be complementary. And on the financing, I know this will come up later, but I think Rogers's question was really excellent. And I think this is somewhere where, just as an evaluator, I've observed on the implementation side, a lot of creative thinking has been sparked about how the county can, reorganize itself to, better leverage existing financing sources. So, better and more systematic reimbursement from the National Health Insurance Fund and from the Linda Mama program, which theoretically reimburses facilities for deliveries performed, but they have to claim those deliveries. And so there is, in some sense, some additional resources that can be claimed, and I'm sure the Jacaranda team and others can speak to that process in future sessions.
Great. Thank you all. I think it's time for a break, maybe some coffee, stretching your legs. So we'll maybe reconvene in 15 minutes. So 10:05. We'll come back and then we'll head to the second half of the session. Thank you.
at you. Don't like when I'm with nobody else. I couldn't help it, I put you through hell. I don't know why I run away. Oh boy, I'll make you cry when I run away. But take me back, 'cause I wanna stay. Save your tears for another. I realize that it's much too late, and you deserve someone better. Save your tears for another day. Save your tears for another day. Tears for another day. Tears for another Save your tears for another day.
The club isn't the best place to find a lover, so the bar is where I go. Me and my friends sat at the table doing shots, triple bars, and then we talk slow. And you come over and start up a conversation with just me, and trust me, I'll give it a chance. Now take my hand, stop, and the man on the jukebox, and then we start to dance. And now I'm singing like, girl, you know I want your love. Your love was handmade for somebody like me. Come on now, follow my lead. I may be crazy, don't mind me. Say, boy, let's not talk too much. Grab on my waist and put that body on me. Come on now, follow my lead. Come on now, follow my lead. I'm in love with the shape of you. We push and pull like a magnet do. Although my heart is falling too. I'm in love with your body. Last night you were in my room, and now my bedsheets smell like you. Every day discovering something brand new. I'm in love with your body. 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 Every day discovering something brand new. I'm in love with the shape of you. When we came, we let the story begin. We're going out on our first date. You and me are thrifty, so go all you can eat. Fill up your bag and I fill up the plate. We talk for hours and hours about the sweet and the sour and how your family's doing okay. And leaving, getting a taxi, kissing the backseat, tell the driver make the radio play. And I'm singing like, girl, you know I want your love. Your love was handmade for somebody like me. Come on now, follow my lead. I may be crazy, don't mind me. Say, boy, let's not talk too much. Grab on my waist and put that body on me. Come on now, follow my lead. Come on now, follow my lead. I'm in love with the shape of you. We push and pull like a magnet do. Although my heart is falling too. I'm in love with your body. Last night you were in my room, and now my bedsheets smell like you. Every day discovering something brand new. I'm in love with your body. 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 Every day discovering something brand new. I'm in love with the shape of you. Come on, be my baby. Come on. 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 Come on, be my sheets smell like you. Every day discovering something brand new. I'm in love with your body. Come on, be my baby. Come on, I'm in love with your body. Come on, be my baby. Come on, I'm in love with your body. Come on, be my baby. Come on, I'm in love with your body. Every day discovering something brand new. I'm in love with the shape of you. To the heart, I never kissed a mouth that tastes like yours. Strawberries and something more. Oh yeah, I want it all. Lipstick on my guitar. Fill up the engine, we can drive real far. Go dancing underneath the stars. Oh yeah, I want it all. Got me feeling like I wanna be that guy. I wanna kiss your eyes. I wanna drink that smile. I wanna feel like like my soul's on fire. I wanna stay up all day and all night. Yeah, you got me singing like, ooh, I love it when you do it like that. And when you're close up, give me the shivers. Oh baby, you wanna dance till the sunlight cracks. And when they say the party's over, then we'll bring it right back. And we'll say, ooh, I love it when you do it like that. And when you're close up, give me the shivers. Oh baby, you wanna dance till the sunlight cracks. When they say the party's over, then we'll bring it right back into the car. On the backseat in the moonlit dark. Wrap me up between your legs and arms. Ooh, I can get enough. You know you could tear me apart. Put me back together and take my heart. I never thought that I could love this hard. Ooh, I can get enough. Ooh, you got me feeling like I wanna be that guy. I wanna kiss your eyes. I wanna drink that smile. I wanna feel like like my soul's on fire. I wanna stay up all day and all night. Yeah, you got me singing like, ooh, I love it when you do it like that. And when you're close up, give me the shivers. Oh baby, you wanna dance till the sunlight cracks. And when they say the party's over, then we'll bring it right back. And we'll say, ooh, I love it when you do it like that. And when you're close up, give me the shivers. Oh baby, you wanna dance till the sunlight cracks. And when they say the party's over, then we'll bring it right back. Baby, you burn so hot, you make me shiver with the fire. You got this thing we started, I don't want it to stop. You know you make me shiver. Baby, you burn so hot, you make me shiver with the fire. You got this thing we started, I don't want it to stop. You know you make me shiver. Yeah, you got me singing like, ooh, I love it when you do it like that. And when you're close up, give me the shivers. Oh baby, you wanna dance till the sunlight cracks. When they say the party's over, then we'll bring it right back. Oh no, say, ooh, I love it when you do it like that. And when you're close up, give me the shivers. Oh baby, you wanna dance till the sunlight cracks. When they say the party's over, then we'll bring it right back. Hey.
Do you ever feel like a misfit? Everything inside you is dark and twisted. Oh, but it's okay to be different. Cause baby, so am I. So am I, so am I, so am I. Can you hear the whispers all across the room? You feel their eyes all over you like cheap perfume. You're beautiful, but misunderstood. So why you tryna be just like the neighborhood? I can see it, I know what you're feeling. So let me tell you about my little secret. I'm a little crazy underneath this, underneath this. Do you ever feel like a misfit? Everything inside you is dark and twisted. Oh, okay to be different, 'cause baby,
I do the same thing I told you that I never would. I told you I changed, even when I knew I never could. Know that I can't find nobody else as good as you. I need you to stay, need you to stay. I get drunk, wake up, I'm wasted still. I realize the time that I wasted here. I feel like you can't feel the way I feel. I'll be fucked up if you can't be right here. I'll be fucked up if you can't be right here. I do the same thing I told you that I never would. I told you I changed, even when I knew I never could. Know that I can't find nobody else as good as you. I need you to stay, need you to stay. I do the same thing I told you that I never would. I told you I changed, even when I knew I never could. Know that I can't find nobody else as good as you. I need you to stay, need you to stay. When I'm away from you, I miss your touch. You're the reason I believe in love. It's been difficult for me to trust. I'm afraid that I'ma fuck it up. Ain't no way that I can leave you stranded, cause you ain't never left me empty-handed. And you know that I can't live without you. So baby, stay. I'll be fucked up if you can't be right.
Hi, everyone. We can get settled back in. And as you're all getting back in, if you could grab a translation device, which is at the back table, so that you have that for the next session, please. No, I'm trying. Thank you. Great, thank you all. Please feel free to bring your coffee, water, biscuits inside. We're gonna get started. The next session is broken up into two parts. We'll first start with looking at some country examples of where SDR is currently being implemented and hear from the experiences. So we'll have three speakers. I might ask the speakers to go up to the front, if that's okay. So the first speaker will be Ana Maria Nadal, who's the Minister of Health in the province of Mendoza in Argentina, to talk about the experience around SDR for improving PHC in Mendoza. This will then be followed by a discussion on the MNH SDR experience in Kakamega in Kenya, where we'll have Sati Rajashekharan, who's the co-executive director of Jacaranda Health Kenya, to come and to walk us through that experience. And then last but not least, we'll connect with Keith Clotey on online, and he will walk us through sort of the MNH system redesign that's happening in Western Cape in South Africa. And Keith is the head of the department in the Western Cape Department of Health. So it'll be three presentations. And again, we'll pause after those presentations, take some questions before we move into a larger panel discussion where we'll have more time for more interaction and discussion. So Anna, I'll send to turn it over to you. Yeah. And then just a reminder, please grab the translation devices at the end of the table. I think this presentation will be in Spanish, so I will encourage everyone who is not as fluent in Spanish to please to collect a device.
Okay. Muy bien. Muy buenos días. Muchísimas gracias a todos. Gracias a la Fundación Bill Gates por permitir a la provincia de Mendoza participar en este simposio y bueno, por permitirnos contarles la experiencia de una provincia, de la quinta provincia en concentración demográfica de la República Argentina, y contarnos nuestras experiencias, nuestra mirada de presente y de futuro del sistema de salud. Bueno, muy brevemente, en honor al tiempo del que disponemos, me parecía muy importante contextualizar la provincia de Mendoza y el sistema de salud de nuestra provincia en el contexto nacional, y también entiendo que compartimos con algunos países de Latinoamérica que tienen que ver con la mirada de que en nuestro país, con rango constitucional, la salud es un derecho, pero todavía nuestro sistema de salud está altamente caracterizado por la fragmentación y la segmentación de los servicios de salud. La fragmentación está estrechamente relacionada con una organización y una conformación muy compleja del sistema de salud en Argentina, donde subsisten muchos niveles financiadores. Tenemos financiación de la medicina prepaga, seguros privados, de la sociedad, de la seguridad social, también de las personas que no tienen un trabajo formal y su cobertura está dado por el fisco, es decir, por el Estado, quien da la cobertura de estas personas, y también tenemos múltiples proveedores de servicios de salud, tanto el subsector público como el subsector privado, con lo cual nos hacen un sistema en general muy complejo, con bajo nivel de integración, en lo que a futuro, en reformas sanitarias, se hace pendiente avanzar sobre niveles de integración y sobre la reducción de estos niveles de fragmentación de los servicios de salud. Esta fragmentación trae como consecuencia también una segmentación en el acceso a los servicios de salud. Lamentablemente en la Argentina aún tenemos brechas, en mi provincia también, brechas de acceso que están relacionados con los niveles de ingresos y los niveles de cobertura. Si bien el acceso en nuestro país no es la situación de mayor dificultad, porque todas las personas de alguna manera tienen protección financiera para las prestaciones de salud, ya sea por los estados o por los sistemas de financieros, pero sí tenemos una alta desafío, un alto desafío y una necesidad de disminuir las brechas de calidad que tienen las personas que acceden a los sistemas de salud según su cobertura. Es decir, podemos decir que todavía en nuestra provincia a veces nos enfermamos por cómo vivimos o de qué trabajamos. Estos grandes desafíos hacen que tengamos no solo una fragmentación entre todos los subsistemas en general del sistema de salud, sino también avancemos sobre una fragmentación institucional hacia adentro de nuestro sistema, y yo especialmente en honor al tiempo me voy a referir al subsistema público en todo lo que hoy les podamos compartir. Y esta claramente, esta fragmentación de servicios de salud nos da como resultados que verdaderamente deseamos y tienen que ser un desafío a superar. Todavía tenemos barreras de acceso, todavía tenemos dificultad en proveer cuidados continuos, del mismo modo que nuestra atención de salud muchas veces está orientada hacia el cuidado episódico, la dificultad de articular y los niveles de atención, también con claramente una baja calidad técnica a veces en las prestaciones de servicios de salud, y claramente un uso ineficiente de los recursos en muchas oportunidades, lo que trae aparejado mayores costos en la atención. Obviamente todo esto tiene como una consecuencia una baja satisfacción de los usuarios. Esto que es una realidad que estamos tratando de cambiar, y ahora me voy a referir puntualmente a la provincia de Mendoza. Desde hace ya bastantes años, 7 años, 10 años, que venimos en un proceso de transformación del sistema de salud, nos hemos propuesto avanzar sobre modelos integrados, sobre redes integradas de servicios de salud, justamente que saquen el foco de lo episódico y que saquen el foco de la enfermedad para poder poner el foco en la persona, para generar redes integrales, integradas, longitudinales de servicios de salud con foco en las personas y fundamentalmente basadas en el primer nivel o por lo menos en la estrategia de atención primaria de la salud, atravesando todos los niveles de atención, entendiendo que la salud no es solo un proceso que está circunscripto al subsector que presta servicios de salud, sino la salud es verdaderamente una dimensión social y política en donde verdaderamente para hacer una verdadera atención de la salud tenemos que intersectorialmente trabajar con otras áreas como educación, seguridad, desarrollo social. Entonces, en este sentido, pensamos el sistema de salud como una red en donde el centro de la red son las personas y tratando de articular todos los niveles adecuadamente de atención. Bien, ahora sí seguimos. Bueno, esta es nuestra provincia. Quiero comentarles que somos aproximadamente 2 millones de mendocinos los que vivimos en nuestra provincia. Estamos en transición demográfica con un aumento progresivo de personas mayores, aumento de la edad de las personas también. Tenemos una particularidad que nuestra población se concentra en oasis, la provincia es un desierto, se concentra en oasis que están fundamentalmente la densidad ubicada en la metropolitana norte y en la metropolitana sur, que es el norte de la provincia, con una importante cantidad de personas que viven en sectores rurales, en donde también se hace más dificultoso llevar prestaciones de servicios de salud. En este sentido de red que yo les mostraba y como pensábamos la organización del sistema de salud, es que hemos conformado una organización estructural y organizacional de nuestro sistema, organizándolo en redes sanitarias. Y dentro de esas redes sanitarias, generando gobiernos locales que permitan articular desde el primer nivel de atención hasta el establecimiento que tenga mayor complejidad en esa región sanitaria con un gobierno local que tenga una íntima relación con el gobierno central que define las políticas de salud para poder llevar a cabo políticas territoriales de una manera más cercana y más articulada posible. Esta es nuestra lógica de construcción de red en cada una de estas 5 regiones que son en las que se organiza el sistema de salud de la provincia de Mendoza. En nuestra provincia, el 48% de la población tiene cobertura exclusiva a cargo del Estado, es decir, el Estado de la provincia con recursos fiscales financia la salud de las personas. Bueno, esto un poco nos organizamos como red, tratamos de generar esta organización de los servicios de salud dentro de cada una de las redes, pero bueno, la pregunta es, ¿con qué primero, a quiénes y cómo? Entonces, en este sentido, esto es una de las propuestas de las políticas priorizadas del gobierno de la provincia de Mendoza, del Ministerio de Salud, entendiendo cuáles van a ser nuestros ejes priorizados y estamos trabajando fuertemente en la salud materno-infantil y en las adolescentes. Años, entendemos en los adolescentes un segmento de la población que requieren un cuidado especial. Estamos en un proyecto particular de un espacio integral de salud de adolescentes con una mirada absolutamente integral de su salud. Este es uno de los proyectos priorizados del Ministerio de Salud, mirando de cara a lo que es el presente, pero también construyendo políticas sólidas que tengan una mirada por lo menos de 10 años, ¿no? Mirando hacia adelante, hacia dónde planteado en una necesidad. Nosotros tenemos una necesidad profunda de hacer una transformación digital del sistema de salud de la provincia de Mendoza. Esto es para contar con datos de interés, interoperar sistemas, tener datos fiables y poder construir.
Untransmissible chronic diseases and to see the expectations of the users and those that we implemented, and we have this development to be able to know how users know and how they get involved, that how much they trust the health system. And then we evaluated resources and limitations that we as providers have so that we can evaluate the implementation of redesign. And as the last point, to have this redesign proposal for this point for chronic disease attention.
I'm just gonna move quickly. This is the data sources, what we've got for our results. I'm gonna go even faster to talk about the results. We can see that based on the consultation of our data, querying our data and looking at the data regarding medication consumption, also the clinical records, unique digital clinical records that we have implemented, we see there's under registration 56,000 people with high blood pressure, out of which we see the behavior. Most of these people, they go to the doctors at first level, second level, and the greater, or actually the smallest, go to the third level of service. Very quickly, just for you to have an idea what this means to us, the first service level means a set of facilities we believe to be ambulatory consultation, lower complexity. The second level already has a little bit more, has some inpatient, but minor complexity. And the third service level includes hospitals in the province. That is the highest level of service in our district and with the greatest complexity of cases. Okay, the behavior, I need to move more quickly. Per age group, of course, most of these people are between 35 and 60 years of age. And also, most of these people, they come to this doctor's office 1255 to the health service. Here we can see the user patterns for diabetes is pretty much the same. Number is identified 25,000 patients with similar behavior in the consultation.
Consultation, the grade of the consultation, the first several.
And how to send the signal to Zoom. Sorry about that. We see that a figure that has called our attention is we can say it again that we need to improve the records. That's why there's this need of digital transformation. But we are concerned about the number of young people from 0 to 24 years of age that have some depression diagnosis. Also, the number of doctor visits that most people go visit doctor is 1 through 5 times since 20 or in the year 2019. About the expectations of preference users and non-users, we've used two tools, one qualitative tool and also a quantitative tool. The qualitative tool focuses on focus groups. We've asked people, there's been interviews, 5 focus groups, 5 from the private sector and from the public sector. I forgot to tell you that this study is being conducted in a population that has to do with the public subsector and provincial social work that has 400,000 members. And between the two sectors, they make up a very important number of the population in our province of Mendoza. I'll move on. We have carried out, or we have developed tools, like I was saying, qualitative and quantitative. The qualitative is focus group. The quantitative is to hear the patient's voice. We are doing that. We have selected 1,000 people and we have interviewed 350. We've done this with the company that was hired. It was Ipsos, and we want to thank them also for the cooperation, the Swiss International Cooperation Agency that has co-financed the survey. And I want to show you the results so far. The province of Mendoza, there are 53.5% of people who go to public sector and 24% and then 21%, 24% private and 21% social work of the analyzed samples. The reason why they go to those places basically is the closeness and the service quality, because it's just a place they are supposed to go to based on the coverage. From the options we asked, about 71% of people say that the health system has good conditions, but there are situations that need to change. 16% of them report that it works well, but they would like to see minimum changes. And 11% they feel that the health system in Mendoza province should be rebuilt completely. Now, about the question we asked about the COVID management, most of the people reported that the government was good and excellent between those ranges. This is data related to the performance and the use of services. And beneficiaries who had to visit the doctor for key consultation, but still we have gaps. We can show them here clearly. They need to improve the health provision services to reduce gaps in diagnosis. Basically, it's in eye consultation, mental health. We also have see a big gap, an important challenge in the number of early diagnosis of breast cancer and also the screening of uterine cancer, where we've implemented different type of tests, HPV, things, and to be able to close that gap. Now, those who needed the health services service and we're not able to access it. We only have in this population under study 22.3%. And the main response we received about this inability to access is because they delayed get turned, or because there was no medication available in the health system, or the specialist was not available. This shows the situation of the health system and how many users think of it well. Only 15% said they had received good treatment, but another 15% reported some discrimination. The reason why they visited the health system had to do with the preventive care. That was 47%, 27% emergency cases, and 22% so for some chronic care. Some more of the tools that we used for the qualitative assessment, we have a cohort of patients with diabetes. It's a project we're about to start. It doesn't have to do with the reason why they went to the doctor, but whether they can receive continuous care. I need to move on faster. This is the inclusion criteria about the assessing the limitations and the chances of the health suppliers to move on in redesign proposals. We find basically that given a survey that was conducted, we had some answers regarding the multiplicity of tools and the lack of time, the inability to be able to move on. In redesign, this poses a challenge to improve and manage change. That's all from my side. Now, I hope that I was clear, but I can tell you that as Minister of Health, the province of Mendoza, we clearly take on this responsibility. We need to close gaps. We need to improve our health system to reduce the gaps, mainly speaking of access and also quality. That's why I believe that every policy that we may implement today, we need to do that as fast as possible. Make sure that the health system gets reformed, that sees a transformation. We believe in the redesign of the system. We believe this is a window of opportunity. And we firmly believe that even though I'm going to be there for just one more year, I do believe in these strategic partnerships to establish policies that are long run and long term and improve the quality of people's health, especially those that are more vulnerable and need the care of the state to guarantee their right to health. Thank you very much.
Very much. That was a very rich presentation. I will again ask folks, if you have questions, please write them down. We're going to go through all the presentations and come back to your questions. So next, we'll be moving to Sati, who will be talking about the experience of SDR.
Hi, everyone. Let's see. Oh, no. There we go. Quick housekeeping notes. Before coming, my kids decided to give me a cold, so I'm pretty much recovered. It is a cold, but I may pop over to get some tea, so that explains the voice. The other one is, in transit, I lost my glasses. So if you ask a question and I do this, I'm not meaning to be rude. I'm trying to see a little bit better. So I'm Sathi Rajashekharan, Co-Executive Director at Jacaranda Health. Everything I present today is on behalf of Kakamega County. You've heard about the county. I want to recognize their leadership in bringing this work together and delivering it. And I wanted to share some highlights from what we've learned about the work to date. Super quick background, a little bit more about Kakamega County, and some of the solutions we put in place for redesign, and then what we're learning as those solutions are being deployed. So super quick, Jacaranda Health is a nonprofit organization. We've been working in Kenya for 10 years. We work with government health systems with county governments, so the administrative units that deliver health in the country. And we deploy solutions in partnership with the government. So some of these solutions I'll talk about today, focused on the mom, text messaging, for example, but also focused on the provider. And our sort of mission is always, how do you deliver sustainable change? So not just solutions that are being deployed and then we disappear in a couple of years, but what's the framework for true ownership of the government by those solutions? How do you bring that in right at the start of any initiative that you put together? So our involvement in this process came right after the results from the feasibility assessment in Kakamega were put forward, were released to the county. And I thought I'd talk a little bit about, fantastic work and is published, the sort of the crux of it in terms of Kakamega, because you've heard about this county, but what is it about this county that lends itself to service delivery redesign? And I think some of the statistics that really stand out are the vast majority of deliveries are being conducted in low volume facilities. That means that, the vast majority of facilities are not conducting a lot of deliveries. In other words, there's a mom going to the facility maybe once, twice, 3 times a week. The rest of the time it's open. It's probably doing a couple of other things. It's probably primarily a primary care center. But when it comes to delivery, it's just there to provide the service. And in fact, they're not equipped to provide that service if we consider the principles that we've all been talking about. They're by no means CMONC enabled. And if we look at skill levels at the facility and equipment availability at the facility, one would even consider whether they should be doing deliveries at all, right? And yet, because of the density of Kakamega, 99% of the women live within an hour of a CMONC facility, a facility that can provide comprehensive emergency obstetric and newborn care. So given this, I'm skipping over a lot of work, stakeholder engagement, trying to figure out what makes sense for Kakamega, bringing that ownership aspect, helping them to prioritize what they want to focus on in terms of solutions that they want to put in place before we even implement the policy shift of having mothers deliver in CMONC-enabled facilities. And what we did is worked with the county government and a series of partners to deploy solutions that are affordable to a government budget, so they can be rolled into a government budget feasibly, and that they're not too, out of the picture in terms of operations of a government health system. So by and large, what we try and do is integrate and co-deliver with the government. So I'll talk a little bit more about some of these. For example, moms getting information about their pregnancy through a digital health platform, or providers getting continuous skill improvement at the facility. But we have other solutions that we've put in place, such as emergency transport that is not meant to achieve that 30-minute mark in SDR, but is meant to resolve some of the major challenges we have in Kakamega with inter-facility transport. That is the prime reason we have emergency transportation in this mix. And then the other picture the other solution I just wanted to highlight was the focus on blood. So Kakamega has a severe blood shortage, both in terms of supply, but also in terms of even knowing which facilities have blood, which ones don't. And so we created a system by which they could track where blood is available in the event of an emergency. So I would say along a mom's journey, these are stopgap solutions as we continue to improve the quality of care in the CMONC facilities and in the primary care facilities for antenatal and postnatal care. So what does this mean for a mom in Kakamega today? So today, a mom in Kakamega signs up for an SMS service, text messaging service. She can do this in the community with her community health worker, or she does this at the facility, and she gets information about her pregnancy. She has access to text into a help desk, or the help desk agent will call her if she has an issue, and then she gets advice on a referral. One really important piece of this is we're also collecting feedback on what happens at the facility. So after every appointment, the mom, does a check-in. She's like, I got, my ANC profiling done. I got my blood pressure taken, but I didn't receive a danger signs talk. And we have a lot of engagement and response from mums on this, and it gives us a lot of rich data. I'll come back to that later. At the provider level, this is, a very common issue. Providers get trained in a training once a year. They go out of their facility, they come back, they forget everything within 1 month. It's totally understandable. There's transfers. So we focus on in-facility training delivered by government midwives. So the midwives are upskilled to train their peers. And a really important piece of this is the data that's coming through. So we know what the skill level of a provider is on their neonatal resuscitation test that was taken maybe 2 weeks ago. We know how they answered their questions when they had a continuing medical education lecture. And that gets aggregated and rolled up to give us a data point on readiness of the providers to handle an emergency or even to deliver quality care. And the health system manager, and this is super important and kind of highlights some of the questions that were coming through. So there's a lot of data that's coming through for the health systems manager. They're able to see what's happening at the facility from the client perspective, right? So they know what the clients are upset about. Long wait times or students being the ones who are delivering services when the health system manager paid for a full-time staff member there, right? So this gives them an extra data point. Importantly, there's a lot of work that we've put in place on the financing side of things. So we've worked at the policy level in the county to shift the policy from what was before, which is when a mom with national insurance comes in and maternity care is free, the money from that service goes straight to a central account. And that facility likely does not see that revenue coming in. There's no incentive to collect, and certainly no incentive to continually badger the central county to ask for money to improve their facility. And so what we've worked on, painfully, I would say, to implement is the Facility Improvement Fund, which is now in policy and allows a facility to reclaim its own revenue and institute improvements at its facility, sort of basic stuff that it can do to improve care and bring more footfall, which then brings in more revenue. And so putting all this together gets us this kind of, I would say, pre-implementation results, right? So we have almost half of the mums in our phase 1 sub-county. So we've phased this approach, as you've heard already, who are enrolled into prompts. And now we're deploying a lot more community health worker-enabled enrollment to get higher. We have had really good results in terms of skills and knowledge coming through in the last round of testing for providers, which is great. And there's a really interesting stat on this emergency transportation. So our solution provider for emergency transportation is called Rescue. It's a little bit like Uber for ambulances. So it aggregates public and private sector ambulance supply so that instead of relying on a government ambulance, you have whatever ambulance is closest to come and support the mom. And so we've got those referral times down to 23 minutes. That is not the SDR success metric, because we know that when that mom gets to a facility, she's often waiting for an hour. So we still need to improve the capacity of the facilities, which is what we're doing through increased bed capacity and staffing. And blood fulfillment is improving, but not as good as it should be. The final stat up there is the cost share from the government. So the county has committed and has delivered on placing staff in the facilities. But as I'll talk about a little bit later, this is not just a one-time thing. This is not just a budget allocation process. You have to continually monitor revenue that's flowing through the system to ensure that things don't fall apart. So I like to think of this slide as the justification for SDR. And I'm going to explain it just a little bit. What this shows is the ambulance transfers that have happened over the course of the last 6 months. Blue is a CMONC facility. We're seeing the percentage of CMONC transfers, so transfer from a hospital to a higher level facility, dropping. But when you look at these cases, if this facility was well equipped, it should not have been transferring out. And so clearly we have a weakness at the highest level or the mid-level of the facilities, demonstrating that we need to improve care in those hospitals. The green line is health centers. We have a steady stream of referrals from health centers. And what I mentioned before is those health centers aren't doing very many deliveries. So they're referring a lot of mums. And so this is a justification to say, this is not sustainable, right? You can't just refer mums constantly from a health center to a hospital. This is why you need to redesign that network so that you have better care for the mothers. And then finally, the orange line is a surprising one that's been coming up, is now that mums know a little bit more about this referral service, we're seeing a lot more mums, or we're picking up a lot more mums with that delay in care seeking, right? Signs of labor, and they wait perhaps too long, and so we have to transfer them via ambulance. So why is that? We know from the mums that they're not being educated on danger signs or signs from labor, and that's from prompts, right? So that's from the SMS platform. Mums are telling us, I never heard anything about what a sign of labor is. So how do we expect them to make a decision based on that trigger? But we know when a mom gets advice from a provider, they are very likely to go to care. There's a lot of trust there. Having said that, we also need to understand the distinction between the trust levels at a community health center, where someone may know the nurse personally, and a hospital where you're anonymous. And we've worked on design solutions like ticketing to make the mom feel less anonymous. And this was a huge piece of feedback from the moms. We want to be cared for at these facilities if we go to them. So we need that experience to be better. Oh, all right, so make sure. So often I find this cartoon really demonstrates how we feel about the situation sometimes, which is if we're plugging gaps, it often feels like there's something else that's going to pop up. And this is not the way to redesign, right? This is intermediate solutions. We had the elections in Kenya last quarter that diverted funding to a lot of different, priorities. And we're seeing the impact at our phase 1 hospitals right now. No funding for commodities, no funding for supplies. When there's no funding for supplies, staff don't want to work there anymore because they're not seeing clients. They transfer out. They're getting job requests from other counties. And so what we've decided to do is to put this all together for our county health managers in a singular dashboard where we can have razor focus on the critical metrics for SDR, right? Appropriate staffing, appropriate infrastructure and equipment, the right kinds of referrals happening at facilities. And I wanted to draw your attention to a couple of things. One, you see the revenue in some of the facilities is incredibly low. So they don't have money to buy commodities. The next row shows you that essential commodities are non-existent, basically. They cannot deliver services in these facilities. And this helped us identify a weakness that's not just specific to funding, it's also specific to supply chain and quantification, which is something that we'll work on. So the bottom line, and this is the last slide, is that you have to bring the leadership of the health system to look at this data, not on a one-time basis, but continuously. And it's got to be all green, right? There's no point doing 6 greens and 3 reds because it's not going to work. And we're working pretty hard on this with the counties, and we're seeing a lot of positive outcomes, right? They get it. They understand that the system needs to be operational, and now we have metrics from that data across the solutions to tell us, how is this working? How is this working this month? So let me end there, and thanks very much for your attention.
Thanks, Sati. We might move in the interest of time just to our last presentation. So this is with Keith. Keith, can you hear us?
Yes, I can hear you. Can you hear me?
Yes, and we can see your screen. So please go ahead.
Okay, I will stick to my 15 minutes and I go. So I'm going to give a context description to start off with, then the rationale for health system reform in the Western Cape in South Africa, then the maternal neonatal system redesign approach, and then also a population health outcomes approach to look at the impact as we go. So this is a context description. The Western Cape is one of 9 provinces in South Africa. Everybody probably would know of Cape Town and of the beautiful scenery in the winelands, but we have 7 million people. We have 550,000 living with HIV, more than 50,000 new TB cases each year, and about 120 deliveries per year. That's public and private. So when we look at our, let's call it our disease profile, and this is based on years of life lost And this is the data we have in our data center, but I'll come back to later. But you can see in 2016 and when we go closer to 2021 with COVID added, you can see the quadruple burden of disease that our healthcare system responds to. You'll see the first one. I'm just going to concentrate on the first one, which is the perinatal outcomes, which is I've circled in red. But just a little bit later on, you'll see in the young adults, it's intentional injuries, especially in young males, which basically means 9 to 1 young males in our setting gets killed by interpersonal violence. Then kind of early adulthood is HIV, TB, and then the late adulthood is chronic disease of lifestyle. Obviously, COVID superimposed on that. So this is just a little bit understanding our organizational context. We have 33,000 staff members, 65% of them are health professionals, and 35% administrative staff. You can see roughly about 11 million primary care contacts in a facility, another 108,000 in schools, 2.9 million deliveries of medicines to people's homes and prepackaged by a chronic dispensing unit without them having to come to a health facility. And then also 7.4 million contacts in home and community care settings, taking them away out of primary care facilities. The 96 baby deliveries that you see, that is the public sector deliveries. And I will be speaking mainly about the public sector maternal neonatal redesign. And there's still another 20,000 deliveries that happens in private facilities in our setting. You can see a lot of people transferred by EMS, hospitals, and all of those. So if I then go to the rationale for health system reform in our setting, we have a strategy called Reset, Recovery, and Resurgence. Coming out of COVID, we're taking the lessons of the last 30 months. We're also then saying that the resurgence, we are planning, and we can know we're coming out of it with Omicron for the next 2 years and rebuilding demand for essential services. But very much we are concentrating on the recovery for the next 5 years and the resetting to a UHC agenda, reform and social determinants mitigation for us. It's all contained in a vision that we have, Healthcare 2030, and it's really about a person-centered healthcare system, successfully mitigating social determinants and successfully implementing and scaling universal health coverage reforms. But what I would like to concentrate on is really on the recovery. It's our journey towards that. We've chosen service delivery, governance, and public policy reform agendas to actually underpin that. So what does that mean? Service delivery platform reform. So we want to redesign our service models based on evidence and data so that we effectively respond to that quadruple burden. What I didn't show you on the deaths data is mental health, obviously not from a death perspective, but it's also in teenagers and early young adults. So we want to actually, the quadruple burden, respond to maternal neonatal health. That's where the redesign for maternal neonatal health comes from. But we're not only redesigning maternal neonatal health, we're also redesigning mental health and well-being, violence prevention, chronic disease of lifestyle, and infectious diseases, and surgical backlogs. So we're redesigning all of them all at once. And we believe if you're going to redesign, you might as well redesign for your entire system, not in a piecemeal way. We underpin that also by governance reform, and that's local geographic and also overall policy alignment governance. So it's a local geographic governance reform and a system-wide policy reform that we do at the same time. And then public policy, we found very effectively that with evidence-informed and data-led public policy, we can mitigate social determinants like alcohol regulations, firearm control, road safety, food regulations, etc. So that brings me to the maternal neonatal system redesign approach. So we're basically taking an approach in the following way. Our focus areas is very much access, clinical practice, demand creation, care pathway, and data. Our design approach is the plan, do, study, act cycles in local design hubs, but also on system design hubs. So as we're doing local design hubs for these things, we also do system design hubs. And I won't go too much in the system design hub, but it is actually designing and redesigning whole transport systems, whole supply chain systems, whole pharmaceutical delivery systems, all of those things at the system level. So if I look at the first focus area, access, and this is really about bed norms, equitable distribution of staff beds. We're also looking at student intake. We're looking at obstetric specialists, registrars, and the availability of midwives and ultrasonographers equitably across everywhere. And then widespread provision of emergency contraception and TOPs is a very important thing for us if we look at the full cascade from a non-pregnant woman to all the way to delivery into the first 1,000 days. And then expanding emergency contraceptives as well. And then larger facilities for mothers. So because of distance and transport, we're now also giving mothers with sick neonates lodging facilities to make sure that we contain the mother-infant bond. This is just two examples of this. You can see that our total lives by level of care has increased for district hospitals closer to where people are, while it's decreasing for regional hospitals. And then also you can see the sharp increase in access to TOP services, especially in our densely populated city. The second focal area is clinical practice. And this is probably where we do most of our redesign and have had most of our success. And it's really because we have a very sophisticated death report and death notification process. So it's really the improved management of hemorrhage, hypertension, preeclampsia, fetal distress. Also ultrasound at every pregnancy. We're also now looking at eliminating unsafe cesarean sections. So it's almost like a zero tolerance for a place that should not be doing cesarean sections and it is too difficult or it's too risky to do. Also rapid access to theaters for emergency section is one of the key things we've done. Handheld ultrasound Doppler devices, a range of other things, and then the rapid transport as well. And this is just an outcome of the clinical practice. You can see our early neonatal death, really steady decline in early neonatal death and maternal death specifically as well. We've had peaks during the COVID waves, but maternal death has been on a downward trajectory. And together with this, the early neonatal and maternal death is really important for us to track. And you can see the main causes for maternal mortality in South Africa out of this confidential inquiry process. And this is targeted with our clinical practice protocols in redesign. So then demand creation, very important for us. It's really about the catchy social messaging about uptake of services. There's some very innovative work that's come out of COVID that we're leveraging now for this. And then also what we call the community health worker diet support to pregnant women and new mothers. So it's really that we match up a community care worker with a pregnant woman to guide her through pregnancy all the way for the first 2 years of life. But also birth partners, so that we actually have a birth partner with every person if it's not the parent, the father in the birthing, that there is a birth partner through all of this. And this is also some of our focus area. You can see steady increase in antenatal care coverage, both for under 14 and for 20 weeks across all our areas. The third focus area is care path. The fourth one is care pathways. And this is really where we think the care continuum and making sure that we have the right skills at the right place to do the right thing. And this is where we train and essential skills for healthcare workers across our care continuum. But then big thing for us is provide on-site midwife birthing units at large district, regional, and tertiary hospitals. It is a big, we call it transformation lever for us, and preferentially place advanced midwives in these midwife obstetric units, and then medical support, and then obviously referral pathways across all of this. And the last one is data. We also regard data as a reform area for maternal neonatal health, so that we can have a live dashboard of obstetric and perinatal information on our electronic patient cohort. So I will come and I'll explain to you how we actually track the impact from this, and then obviously improving record keeping, moving towards an electronic system for all data capturing. So the population health outcome approach that we've got, we have something called the Provincial Health Data Center. What we do is we have a unique identifier process, and from multiple sources, we can extract with the identifier of a person and build up an electronic record for that person in real time and serially in terms of all the contacts where they have. What we need is we need extracting, let's call it digitized interfaces wherever that person is into this health data center, and then we build up the electronic data system from that. We have a whole lot of things that we can do, reporting, dashboards, whole lot of intelligence. This is really a nerve center we have, but because it's unique identifier and the uptake is so great, we almost have a real-time research engine to look at any changes we make in the system, to look at the impact we have. And the big thing for us is not the sophistication of the system, but it's really the data competence of people that can actually navigate this and give us a real-time information. So what does that mean? So if what does it mean for maternal neonatal health? We can take evidence from multiple, if drugs has been dispensed, any diagnostic test been taken, diagnostic procedure codes, whether somebody's been admitted to a ward or has had an OPD visit, whether there's M-Health community system, so if community care worker goes to somebody and they upload digitally their interaction and then disease registers. So from all of those, we really put together what we call a pregnancy episode, and we put together a maternal cascade. At the same time, we're also now working on a neonatal into a child cascade. And it's really just about looking at all the data sources, and we can put for an entire cohort what's happening to cohorts in terms of that. So what would maternal cascade, for instance, look like? For the year 2020, out of this data that we can look at pregnancy outcomes, we can look at maternal comorbidities, we can look at maternal deaths, we can look at birth weight categories, we can look at HIV proportion, we can also look at HIV and R timing, and then, as I said, the neonatal cascade, we can also do that, and we can expand this, and as we're going to do, even to pre-pregnancy, to family planning uptake, TOP access, and that's a work in progress that we're doing now. And then just the last one, we can aggregate these supports at the system level, at the geographic level, district level, or at a facility level, and build up these cascades and track everything that happens in the area. So as we're redesigning, we can track the impact of what we're about to do. So in conclusion, we have a clear and systematic journey of health system reform over the past 28 years. It stood us in good stead in COVID because we were reforming our system all the time. In COVID, we also learned new things, how we can fundamentally reset our reform agenda. We are now at a point in time where we can fundamentally redesign services and fundamentally redesign our governance processes through an intentional resurgence, recovery, and reset strategy. And as we redesign a maternal neonatal system, together with a mental health system, together with a non-communicable disease system, together with an infectious disease system, as part of our broader redesign, we can measure impact as we implement the system design as we go. Thank you very much.
Thank you, Keith. We are going to move into a panel discussion now. So I'll invite all the speakers to come up to the front. But I know this was 3 long presentations, but our hope was to show sort of 3 very diverse examples of how SDR is being implemented and taking place in different contexts. So we'll have a moderated discussion next. I'll hand it over to Mickey, who will take us through the discussion, and we will have time for Q&A. We have about 30 minutes, so hopefully all your questions will be answered during the discussion and then during the presentation.
Thank you. And actually, if you do have some burning questions, I will, before we get into the moderated discussions, if you have any questions for the presenters, please put up your hand and I'll take them as well. So as you're sort of formulating your questions, let me also introduce Dr. Jeremy Viard, who is a health specialist, senior health specialist, who covers Colombia actually, and is working in the Latin America region presently. But in his previous incarnation at the World Bank, he was also involved in the global unit with myself, and when we did some work on early work on service delivery redesign, particularly in Tanzania and the Africa region. And so maybe, Jeremy, I'll just start with you. With a question around why is the World Bank interested in service delivery redesign? And particularly in a country like Colombia and this region, which is sort of moving on beyond MNH and some maternal newborn. Why is it still of interest in this setting as well?
Thank you, Mickey, and it's a pleasure to be here and listen to all the amazing work that you guys are doing in many different parts of the world. So I'm the local person here. I'm based in Bogota, covering Colombia and Mexico, and perhaps I can tell you a little bit about the work we are doing and why the focus on service delivery redesign seems very very critical to making progress in effective universal health coverage. I'm just going to give you a little bit of context. Colombia has reached during the pandemic 99.2% of coverage for a basket of services that is very generous, that pretty much includes everything that is not excluded explicitly by the government. And at the same time, it's a country that has been able to keep out-of-pocket payments relatively low. So it's about 15%. So we have a country in which you have the highest coverage and the lowest out-of-pocket. The government or the health sector consumes about 7% of GDP, yet there is huge frustration about the performance of the health sector. And what you see is that, despite the surface that the country is doing very well, and it's actually a great example for other countries in a region and globally, the practice is that accessing quality care has become atrociously difficult, to the point that citizens decide to exercise their right to health to a pace of about 250,000 complaints that go to the Constitutional Court for people to actually get access to the services that they want. And so, it's a very dynamic situation. Obviously, we have a new government in place, and they have, their commitment is actually to ensure effective access to services. And I think that's where the service delivery redesign component comes into place, because what you realize in practice in a context like Colombia is that it is one thing to say that you have theoretically access to services, but when you have to wait for months and months to get access to services, or when the administrative hurdles are so high that you cannot access them, you need to ask yourself the question about what are the barriers to ensuring access to quality services for all. And what's becoming very interesting is that we have a government that's really, I think, asking the right questions and taking a bit of a quality lens. And that's perhaps the first point I wanted to make, is that we talk a lot about service delivery redesign. To me, very fundamentally, it's really putting quality and the patient's perspective, experience, and outcomes at the center of the ecosystem of service delivery you're reorganizing around them so that their needs can be met. What is very interesting to see, so to me, the consequence, and what I'm also teaching global quality of care at the University of Toronto, and what I always tell my students, that quality is really asking the why questions and asking it many, many times. Why do we see those type of results? And very often they're actually an expression of the failures and barriers and poor design of the system as it's experienced by the patients. Obviously, the most vulnerable populations are the ones that are, suffering the most from this poor design. And what we're seeing in Colombia is that, when it comes to rural and remote areas of the country, which covers about like 50% of the territory and millions of people, they have virtually no access to care. So there's a very important strategy around trying to design an ecosystem so that patients can have access at a minimum to multidisciplinary primary health care and to services and to an extension of services into the community, so that it can be a really good understanding of what are their necessities in terms of prevention and health promotion. And so the strategy that the government is putting forward is really, building a system where there is effective access to care. And I think they have a very interesting formula, which is to say that they want the system to be preventive, to be promotive, and to be predictive. And so I think these are very interesting reflections in terms of service delivery design. And I'll be very quick, because in a sense, it's of course making sure that you have effective access to care, but it's also making sure that you have access to care at the appropriate time, and that the populations that are the most at risk of developing adverse or ill health over time can be identified early. And so from that perspective, having the predictive analytics, being able to know what subpopulations are the highest risk, being able to reach out through community health workers, bring them into primary healthcare that is integrated with social care, that tackles social determinants of health, and that can take actions of prevention and health promotion, is critical in that reform.
Terrific, thank you. And I suppose Jeremy summarized many of the key principles that we articulated in the beginning of the morning around what is service delivery redesign. It's deliberative. It's a deliberative thinking of the whole system, and it's taking the perspective of the user and the client first and foremost. And he brought in another element there of equity, particularly the worst affected and the most vulnerable in particular. But what we also saw from the presentations from the country level was some of the systems that need to be put in place for this to be effective and to work. And so, Dr. Nadal, I want to ask you, one of those key systems that you mentioned, but you didn't, maybe can elaborate a little bit more, is around the digital side and tracking and having the feedback from the users as to what their experience is and why they're going to those different levels of care. Do you want to tell us a little bit more about how you are tracking patients and where they go and how you're getting their feedback as to their satisfaction and the reasons for why they are seeking care at the different levels? Is that clear? You can use that.
¿Ah? ¿Se entiende? Ahí está.
Okay, about that question as to why. I'm sorry, I need to take these off. Why users use those levels of service? There are several responses. First of all, the health system, public health system in Mendoza province is a health system that is robust. The territory coverage very wide. I mean, we're present throughout the whole territory. Even in places of difficult access, there's always a place, a public facility where user may be served when they come for service. Now, from that viewpoint, we've identified users and we need to move on the implementation of information systems where we still need to do some work, of course. I need to be able to identify clearly the users and how they visit and how they do at the different service levels, what kind of service they receive, I mean, and that the patient flow is clearly identified to get from the lowest level to the highest level of complexity. That's why I'd like to say that on the one hand, this kind of robust structure in the health system makes it possible for a lot of people since the very first contact they come to the public services. On the other hand, the care is at all levels. And finally, they need to implement some information system, yes, so that we can make sure we monitor and order the patient flow throughout the health system and also give us information. That's to answer your question where we have gotten the data from for the early stage preliminary data, especially with the have information on the patient's behavior and their patterns based on their visits, service consumption, also their clinical records, especially electronic clinical records. I hope I answered your question.
The other key system that you highlight, and you've done some heroic work around, has been the financing side. And you mentioned how you've managed to get the retention of the payments at the facility level has been an important reform. But nonetheless, even despite this, 50% is now covered by the county and the financing. So it does leave the question of the other 50%. And so do you feel that this is sustainable? What other reforms are going to be necessary for this to be sustainable and to spread to other counties in Kenya?
Yeah, thanks for that. I think we need to build in a lot more capacity building on financing for maternal and newborn health service delivery specifically. That's where the other 50% is hidden. So while you can use revenue as a source, so revenue from someone coming in from a delivery, it doesn't pay for the total cost of that delivery. We know this just knowing how much a delivery costs. The other chunk of paying for that cost comes from the central county budgeting process. And that is currently done as here's a hospital, here's what they had last year, here's what they're going to get this year. And it's impossible to figure out across Kenya, what does maternal and newborn health service delivery cost, right? Like how much are we spending? How much would we spend if we increase or shift volumes of clients? And I think that's a long-term improvement. I think that's multi-year, but I don't see that fundamental systemic change happening without that kind of work that's being done.
Really a sort of mind shift change in terms of the how budgeting and allocate and planning is done at all levels. And this brings me to another interesting, Keith, I hope you're still online, but one of the interesting features that you brought out was how COVID has in many ways given you an opportunity to reset, as you put it, some of these systems and issues. Do you want to expand a little bit more on what do you mean by being able to do a reset? What kind of things were you able to now put on the table after the COVID experience that you weren't able to put on the table as much before?
Thank you, Mickey. I think the key issue for us was the data capability. So this data center that I spoke about, we invested in it prior to COVID. And then when COVID arrived, we could do with that data center something that we thought will take us 5 years to do. And that was to create a real-time dashboard every day by drawing data from multiple sources and giving us a daily update of exactly who got COVID, whether they're in the private or the public sector, whether the person is on record as having comorbidities with diabetes, for instance. We could actually phone every diabetic that we know that got a COVID test, a positive test within the last 24 hours, and started the telemedicine project with them. Now, before COVID, we thought these things would take us probably 5 years to do. So our thinking about what is possible completely changed because of what we could leverage in a very short period of time. And that data center gives us primarily at let's call it clinical service level, a clinician real-time data to help them to improve clinical treatment and outcomes for the patient. And because we have that, we all of a sudden could say, but actually, while we were doing that, we also built a field hospital in less than 4 weeks, 980 beds with an oxygen point next to it in a convention center. At the same time, we got all the PPE stock in, millions of masks and all kinds of things, protective clothing, but we also created a central store and we've completely transformed our supply chain processes at the same time. And then on people management, we scaled our skills development, but mainly our employee and health and wellness programs aimed at healing and grieving and supporting healthcare workers. So because we could bring all of this together, it was a completely different mindset that we are in while we're in COVID. And this time frame of 5 years, 10 years became 2 years, 6 months, that kind of thing. And because of that, we're now sitting with the ability not just to reform and redesign our system for one thing and then look what happens over 5 years. We can actually redesign the entire system, because what we can do from that is what we do for maternal and neonatal health. You could see the parameters that we use: access, clinical care, the demand creation, the ability to actually strengthen your whole care continuum and strengthen data. That holds for TB, for HIV, for diabetes care, the same as it holds for maternal and neonatal health. So we obviously then said, well, that means we've been waiting for a very long time to reform fundamentally our system. We are giving it a go. And I can tell you the early signs is everybody's eager to do it. And we got buy-in from just about everybody in our setting because they can see a leveraging of the credibility of what we built in COVID. Thanks, Mickey.
Thanks, Keith. Brilliant. I see we have 45 contributions on the chat function. I don't know if Ines or Kojo, there are questions for this session.
Yes, there is one question for Satyanath, and Daniel is asking, is this system the same one as the Linda Mama initiative pioneered by the immediate past governor, or is it different?
Thank you. questions in the room, or even now's your time to make comments as well. This is a free flowing. You've been hearing the research, you've been hearing the concept, you've heard some country experiences, comments, reflections. Is this too much to ask to be doing? Yes, and please introduce yourself as well.
Dr. Elizabeth Gitau, representing Kenya Medical Association. I will possibly ask the question from the perspective of Kenya first, in terms of service delivery redesign. From the patient perspective or from the demand perspective, it's easier to push clients towards their better facilities. But sometimes what we've noticed, especially now with Linda Mama and other initiatives in terms of increasing demand and increasing access, is usually in terms of the quality of service that is there. Our maternal mortality seems to have stagnated because we are having more either maternal or neonatal deaths at facility level. So even as we implement this, what are we doing at facility levels, especially from a healthcare worker perspective, in terms of the shortages and the burnout, and also in terms of ensuring commodities are there? The biggest issue, I think, in majority of the countries, and some of the work, I think, we have done in terms of assessing PHC, even at Kisumu, which is a nearer county to Kakamega, has been the issue of blood and the issue of commodities. I don't know how your team is planning to push this with other partners to ensure that this gap, which tends to actually delay our impact of this service delivery design, how do we go about it? Thank you.
Brilliant, thank you.
Thank you all for the great presentations. I'm Michael Peters. One of the threads that I saw throughout the country level presentations was the use of data and these dashboards. So I have specific questions for each of those dashboards. Keith, maybe I'd like to ask how when you see these cascades of care and the individual patient experiences, how does the health department then act on that information? Is there some kind of implementation research or some method of acting to close those gaps? And then Sati, I wanted to ask about the scorecard approach that you use. Is there any way to incorporate community perspective or patient feedback? And then are those transparent or shared back with the community? And then Dr. Nadal, I was really impressed with the NCD and especially the mental health dashboard that you have, and you can see the trend of a lot of depression in youth. I was just wondering how you're using this dashboard to really plan the way that you're providing services in the health system. Thanks.
Good morning, everyone. Jacinta Nzinga, Kemri Wellcome Trust, and also PI Quest Kenya. Thanks, everyone. I guess my question is to Keith. I like the whole idea of taking a systems approach when we think about SDR and trying to improve everything around the system and not just service delivery. But I wondered whether you could talk a little bit more about the governance reforms that you highlighted in your talk. One very important element, but a more software intangible element that a lot of us don't think about as we specifically focus on the hardware parts of the system. Thanks.
Thanks, Jason. Let's get those back, and I'll put a question to Jeremy as well about picking up on Satya's point around the financing reforms and what any experiences or insights you want to share around doing that. So maybe let's start with that last question with Keith, and then I'll come to the panelists in turn. So Keith, do you want to just respond to two questions around governance and a little bit more about the use of the data? Thanks.
So, yeah, thank you to Jacinta. A really excellent question. We spend actually most of our energy on governance reform. And because we spend all our energy on governance reform, it's kind of our bread and butter. So what I mean by it, Jacinta, whatever we're trying for public policy reform with other sectors, and whatever we're trying for service redesign in the system, it's all premised on our ability to govern. And you will hear a lot of what we're doing is we're saying we're doing it ourselves. We are a subnational, a provincial healthcare system. We actually own our own strategy. We do our things. And it's very much premised on creating a culture of good governance. And that's what we pride ourselves on. So what do I mean by good governance? So it's good governance for what I would call governance of health. Because we are really got a good track record. We got clean audits. We use our resources well. And we got credibility and public trust because we govern, our governance of health is so solid and we do things. And a biggest thing for our reform in governance for health is we decentralizing decision-making and capacity to a sub-district level. So we have a reform at the sub-district level. It's the lowest unit of where we want to impact on population health. We have district level, which we've capacitated, and now we're capacitating intentionally the sub-districts. And at the center, we enable and support. And we've moved away from compliance because we built trust in the system for that. That's the biggest thing. But then the most important thing that you hear from what I'm saying to public policy is we governed for health. So we're stepping into a stewardship role and we have influence over the social determinants in other sectors. So what does it mean? The health sector, me, myself, are now being called into all kinds of places and advising and actually telling the premier of the province what law enforcement should be doing to have an impact, because he trusts that the health system will tell you whether the law enforcement interventions are working, what social development should be doing and where, which jobs should be created where, and also what education should happen, because he trusts the healthcare to say whether the efforts of the whole of society has having an impact on the healthcare system. So I hope that explains. It's all underpinned by our very, very strong commitment to a culture of learning, and a culture of the way we show up in terms of building relationships and being kind and open to one another. On the data issue, there's a very strong thing that we learned in COVID, is that the data dashboards that you see is produced predominantly for the frontline workers and the sub-district managers and teams. So the data is designed in such a way that a clinician can say, okay, what must I do to improve the outcomes? And therefore, at the sub-district team, what must we do at the population to increase the outcomes? So the dashboard means nothing unless it is actually linked to action. And therefore, we have created these things called huddles. So it's the thing that came out of COVID. Everybody loves huddles now. I chair a huddle every 2 weeks. And the huddle is about reflecting on the data and say, okay, what system levers and policy should be adjusted based on the data? Listen to frontline experience, and what should everyone go away with and actually tweak in their own setting? And how do we know at our M&E that now happens quarterly? And that's why we're seeing this tremendous increase of things, because that data is real time for TB, for HIV, for maternal and for neonatal health, but also for violence and mental health. So in a sense, that's how we track it. And we got this almost real time built in via huddles to respond on the data to say, what are we going to do? Because everybody's interested to see whether the data is showing whether they're having an impact, because everybody owns it and everybody loves the system. Thank you.
Thanks, Keith. Dr. Nadal, you had a question. Your data was showing the depression and the mental health of adolescents. And so can you maybe tell us a little bit more about how you're using that data for your service delivery redesign as well?
Sí, bueno, con relación a salud mental en términos generales y en el segmento en particular de la adolescencia, creo que la pandemia visibilizó.
That were not there visible before the pandemic. So everything that brought this important health crisis, it made it evident. It made these situations evident, and they demand from decision makers, and it demands clear health policies on mental health. Specifically in Mendoza province, we have a view that goes from implementing attention and first level care. This, like I told you in the presentation, this is more linked to the territorial level, to ambulatory services. So we are working a lot on training. We are training teams, human resources, clinical physicians, family physicians. Those are the specialists that we have in the first levels. They are trained in so that they can start doing this first contention work and attention for those mental health problems. We are structuring matrices with interdisciplinary physicians, social workers, psychologists, so that we have interconsultation for that first level. We're also working with inputs so that we also have all type of materials, because we know that this is an important barrier when medication is not distributed and is all centralized. We're also working on prioritized lines, being able to getting them from specialized centers to hospitals. So no monovalent profile, but to be able to have them hospitalized there with mental health specialists in general hospitals. And we're also working, what you asked about mental health in adolescents, we have this space. We have a very comprehensive space, not only from the mental health, but sexual reproduction. We're talking about food habits, problematic consumption, because we see that in that space is a non-stigmatizing view, that those are places that only people that have problems go. No, we have this comprehensive view, spaces so that we can help and assist them. Somehow they can help with the other spaces that we have in the health system. Sometimes they are not seen in those places. So we are working in those prioritized lines. Thank you.
Thank you. And you had a couple of questions. One was on the data, but also a question regarding, I suppose it might be sequencing, that if we're going to be nudging clients to hospitals and high volume centers, the quality of care may deteriorate even further. So do we first need to fix that before we do that? Or so what is the sequencing question?
Yeah, thanks for the questions. I think there was one question on financing about Linda Mama, and I just wanted to say, yes, we are talking about Linda Mama, which is the national health insurance vehicle for providing maternity care. So we're not creating duplicative systems or parallel systems here. I kind of glossed over it in the presentation, but there is a lot of work being done in terms of improving facility level quality. And I want to recognize the sort of Herculean effort of the Kakamega government in hiring midwives. We've reached our target of midwives that we need to have present based on the facility feasibility assessment, and specialists in the county. There's a really important story that is about the sequencing, where there's a pediatrician placed at one of the facilities, but because we haven't shifted demand yet, he was pretty upset that he was sitting around doing nothing and left. So this is a pretty delicate balance of making sure we're doing facility level improvements, having the facilities prepped and ready, and then bringing in the demand on a gradual basis without overwhelming the system. And I imagine it will be gradual. On the issue of blood, yes, absolutely. Blood is a huge challenge across facilities. I think blood needs a lot of innovative thinking, because we've spent years doing the same thing, do a blood drive at a central level, send it to a blood bank, facilities get blood. What we're doing in Kakamega is not only trying to help facilities identify where blood is. So you're a nurse, you're in an emergency, you need blood, look at the tracker, see who has your blood, and that's working fine. But also allowing facilities through policy to collect their own blood, which means they're more engaged in the blood drives at the community level, which is really important, right? You want to build that linkage between the facility and the community. And then finally, on the question of data, I think just really want to endorse what Keith was saying, which is it's not just about the dashboards, right? Like my favorite story about data is the first time we shared a scorecard with facilities, they said, we don't understand any of this. Can you write it up as a memo? So we automated a memo based on the data, which is people want to know exactly what you're saying and they want to know what the action points are, and then they'll move it forward. And these scorecards are in quite a lot of demand at the facilities because they want to know what clients are saying. On the issue of community scorecards, we haven't done it in Kakamega. It is complicated. It's a very powerful tool, but it costs us 5 cents to get information from one mother. It would cost us 100 times more to get a community scorecard-based information. And we have to think about whether that's sustainable in the long run. So it's not that we don't believe community scorecards work. It's that how do you do this in a sustainable way? Yeah, thanks.
So Miki, I'll just very briefly talk about 3 points: innovation, data, and financing. I'll finish with the financing. On the innovation side, I think it's very important to reiterate that during the pandemic, there's been so much innovation that cannot go to waste. And we need to learn our lessons. So on our side, we will be releasing for Latin America and the Caribbean a new report in January on health systems resilience, through which we try to do a bit of a landscape analysis of some of the innovations we've seen in the region, and there are some that are really really impressive. So I'm just going to give you one which took place in Cali. So that's it's about an hour by plane from Bogota, where through a public-private partnership, a hospital, or actually several specialized hospital in maternal and child care partnered with rural facilities in this part of the country. So that's coverage area for a few 100,000 people. And their starting point was to see that they had stubbornly high levels of maternal mortality. That was not changing for the last 10 years, been between 55 to 60 women a year died during childbirth. And so what to do about it? What they've done is actually relatively simple, and that follows the principles of service delivery design. They've actually used the ability they had to expand their telemedicine capacity, because at the very beginning of the pandemic, Colombia, as many other countries, made it a lot easier to expand the use of telemedicine for different types of service delivery. They built a lot of capacity in those rural hospitals, especially for paramedics who went to pick up women in labor and were trained to be able to deliver, to identify early signs of distress or when there was a need to take urgent action. And then through telemedicine, they had actually, some of their best specialists who are accessible 24/7. They had a number of organizational changes. They aligned incentives. They aligned the reporting, more accountability, more transparency. And so in 2020 and 2021, there has not been a single death of a mother. That's what they've been able to do. And we've seen many of those examples across the region. So I think it's really important that we document those, that we take stock, that we learn what has worked well, and that we think really hard about what will be the conditions under which it can be scaled up. Now, what we have to think about is that there are bad things that have happened with some of those innovations. So for example, you take telemedicine, everybody's saying we need to expand telemedicine, and that's great, but you have seen also very poor care delivered through telemedicine. So how do we make it, or do we scale it up in such a way that you can ensure safety, better quality? And we know that for some type of clinical encounter is going to be very hard for diabetic care, for example. We also need to think about equity considerations. Very often, the most vulnerable don't have the same access to the internet or bandwidth, and the same instruments might not work for them. So that's on the innovation side. On the use of data, I think it's important to reiterate, everybody has been talking about data and service delivery design, because service delivery design, it's really about asking the hard questions and having a much more in-depth diagnostic about what are the binding constraints to achieve the results that you want to achieve. And that's very often through data analytics that you get to a clear diagnostic. What's really interesting as well, I think, is the fact that more and more, what you see a lot of experiments about moving away or understanding the limitation of retrospective data analytics, looking at the past as a predictor of the future, towards predictive analytics and trying to be a lot more targeted in understanding in different contexts, what are the populations the most at risk, and how can we apply service delivery design to meet the specific needs of those populations whose health outcomes are stubbornly bad and poor. So that's on the data. On the financing, obviously, the way you finance services is critical. You can build incentives that can change the behaviors of the actors. And at the same time, there are there are opportunities and also, a lot of constraints. And especially when we think about service delivery redesign, at times you need to take money from healthcare and put it in social care to make it work. And what you see is that the way budgeting is structured in most governments is very rigid, and it's very difficult to get this type of flexibility to move, money from one pocket to the other. We could talk also about, care for homeless people and mental health and so on and so forth. It's very, very difficult. So at times one has to acknowledge also it's difficult for good reasons, because we need also accountability, and we need ways to ensure that corruption is addressed, and very often those mechanisms have been designed with that purpose in mind. So how do we get more agility, more flexibility is something that's very difficult, because it's not only about the health sector. Very often it's the way budget rules are organized for governments at different sectors. It might have to do with the rules of decentralization within governments, and that takes time, and that takes engaging with different parts, of government. I think it's important to say that there are countries where you have legal frameworks also for innovation around those budgeting rules. And in our case, in Colombia, we have the World Bank is supporting the government in implementing multi-year reform project currently, and we're going to do that with a new iteration of a program for results. So we are paying against results, and that gives us the ability to work more multi-sectorally, bring the different actors, define the responsibilities, and find ways to address those binding constraints.
Thank you. So let's have one more round of comments and questions, and then we can draw to a close.
Thanks. Rachel Dessen with Chemonics. So I think you started to touch on this, Jeremy, around the health workforce perspective within these systemic reforms that SDR requires. To Dr. Sanam, we can't do micro interventions, we need, macro. And the pandemic has shown we cannot deliver services without a robust, resilient health workforce. So where are those options in financing, where public sector budgets tend to incur, recurrent health worker salaries? That's half of a public sector budget, if not more. When we look at governance, some panelists and folks spoke to power dynamics in terms of gender, in terms of professions, and how political task sharing can be. So what can councils and associations do to really harness governance, accreditation, regulation roles for high quality services? And there's often real-time data on health workers for transparent decisions that lack. There's not that responsive, immediate understanding of who is where and skilled in what. And these multi-sectoral needs, I think it was great. Kevin was able to highlight the Western Cape example of actually putting pipeline into midwifery education. Where is the education sector? Where's the finance sector? So I'll implore panelists to really consider how SDR can address and sustain these underlying macro HRH challenges, and really see what financing, governance, multi-sectoral approaches can be brought to bear. Thanks.
Thank you. At the back, do you have a microphone? You have a microphone.
Hello, my name is Rodrigo Asua from the Quest Center at Harvard. And I'm curious about your experiences trying to collaborate with other regions, particularly because these efforts have been very local. If you have tried to engage with other municipalities or states or provinces about these issues, and if there's ways to collaborate and not just be like doing this in silos inside your countries. And the second question would be around the I mean, it's a huge effort to make such a big information system, right? And sometimes each province is doing it in their own way in silos. And have you tried to collaborate with other provinces, for example, in South Africa or in Argentina, for having more collaboration in these big undertakings? And how, if so, how has it been?
Hello. Hi, this is Shubham from Sambodhi Research India. And first of all, congratulations to all of the panelists. All these discussions have been wonderful. These are thought-provoking and transformational. I have two questions, and both of those are actually extension of some of the questions that has already been asked. So first is the identity or a lesser level identity data to track patients or community through the patient care cascade model. So for example, in India, we have a national identification number, which is Aadhaar card, but we also have different unique IDs across service delivery platforms. Like for nutrition, a mother will have a different unique ID. For RMNCS services, she will have a different unique ID, which will not match with the national identity. So, and there are, as he mentioned, that there are different systems working in silos. So there are often duplication of information. So are there examples of dealing with this? That first. Second is to actually to the larger audience, and it talks about within the entire discourse of service delivery redesign. One prominent thing to mention is the concept of power. And we were discussing about it, how at the national level, culture within the health system played a major role in establishing a service delivery redesign thinking. And within the power context, we understand that there are power hierarchy between service provider and the receiver of care, as well as between different levels of service providers and policy managers and health systems manager. How do we kind of incorporate practices, theories, which can kind of circumnavigate the issues of power within the health system redesign thinking? Thank you.
Brilliant. Any questions online?
Yes, so Daniel has a question. He says, does Santiana see some of the gains made by the previous government continuing given the new governor in place, or will there be a change in focus approach? The second question is, how can the SDR initiatives be made politically agnostic at county like Kakamega? And then Munirat would like to ask two further questions. Thank you.
Go ahead, Manera.
Can you hear me?
Yes.
Okay. Yeah, thank you so much for all the beautiful presentations and the insight provided, to service delivery redesign. My comments or maybe questions possibly will build on some of the things that have been mentioned. I know that in some countries, World Bank have supported some countries to generate load of specialists. I remember when I was working in Liberia, there was huge investment in this. At the end of the day, we had like 16 gynecologists, but at the end of the day, they can't go to those hospitals where even World Bank are implementing PPM because one, the government is unable to pay them, the condition of service there are terrible, and so on and so forth. And these specialists, they end up, going to Ministry of Health or working in the Ministry of Health, and they are not really deployed that properly to places, to health facilities where the services are needed. So how does the SDR, help us, in this regard? How does the SDR address this kind of challenge? Taking into consideration that there's no way we're going to implement this reform without the capable human resource, being on grant. That's my first comment or question. Then my second question is related to the issue of accountability. And SDR, the role that SDR could play in this regard. We have all these beautiful policies, all this beautiful strategic plan, everything well laid out, sitting on the shelf in the Ministry of Health, but they are not adequately resourced to be implemented and to be translated into action, And so I know that now that we're going to SDR, discussing SDR and we're transitioning to this, Then certain things will change again. We come up with the strategy and everything. But the commitment on the side of the client, the commitment on the side of those players, to actually translate this into action is still a major, major challenge. And I'm just wondering, I'd want to learn from the presenters how SDR can actually help us with this issue of accountability. Thank you.
Thank you. Well, some really profound comments and questions right at the very end of the morning. And we don't have enough time to unpack them all. So I'm just going to ask the panelists just to pick, some key issues that they had in mind to reflecting some. And it's interesting because all the comments were very much similar about the underlying political economy. The systems at the moment are designed perfectly to deliver the results they're delivering, and we're asking to disrupt all of that. So there was a political economy going to scale, but there's also these critical subsystems around human resources, data, and financing. So don't feel obliged to do a comprehensive answer, but maybe just pick some key points that you want to get across in these last part. So Jeremy, you have the microphone. So let me start with you, and then we go across.
Okay, so I'll take the one on the workforce. I think that's obviously critical. Care is delivered by people, not magically, and we need to build a workforce that is able to meet the needs for quality and safety, and try to work a lot more upstream, as I was trying to describe. I think that to me, some of the key points that I like to mention is that number one, very often people are trained to exercise at the top of their training and skill set, but in practice they rarely do. And so I think you've had very positive examples around certainly midwifery, nurse practitioners, and so how to make sure that healthcare professionals can exercise to the full range of what they've been trained to do. Number two, we talked a lot about incentives. We don't talk so much about disincentives. Very often, people are put in circumstances in which it's really hard for them to do what they want to do, like they become healthcare professionals because they want to deliver quality care, but very often they can't, or because of, for example, the way they're paid for fee-for-service, all they do is just pump volumes because that's how they maximize their income. And so how do we think about removing these incentives for good quality of care and safety, and try to put people in circumstances in which they can do what they want? Retention is a big issue in rural and remote areas, and very often the only answer is to give them more money. But people don't want to stay very often because at times they just can't do their job. They don't have like the minimum necessities they will have to deliver the type of care that they want to deliver. So how do we do that? And the third message is really about thinking, about pre-service training. How do we train people to be change agents in these service delivery redesign models, and really like hardwire it into everything they do?
Terrific, thanks. Satya.
Awesome. I think I'll wrap together a couple of those questions. There's a question about how do we make this politically agnostic? I don't think we should be making it politically agnostic. Politics plays a critical role in moving agendas forward, right? We have to recognize the politics of the environment. We have to know who our stakeholders are, right? Who's the leader in the situation? What can they help with? Are they a disruptor or are they a champion? It's messy. It's completely messy, but you have to work through that messy phase to be able to get the reform and continuously work through it. I mean, it sounds like a very pithy comment, but I think it's important to have that in our frameworks and our structures to be like, this is not going to go completely to plan, and we're okay with that. I did want to comment on the health workforce issue. I used to do systems level work years ago, and I think one of the challenges with systems level work is you're not giving political actors and leadership enough short-term wins to keep that momentum going, right? So you could probably convince someone to convene a task force to improve, health workforce management. And that's going to take a couple of years, and then the energy fizzles out. And so the way we look at service delivery redesign is working in parallel with the results, the stories, the wins, and then building that longer term, okay, you know, there's a nurse in Kakamega who's an emergency care specialist who's working in a health center. That's a story. Let's put her in a hospital, right? But what does that mean in terms of your policies? Can we change that? And then you slowly get shifts. And at least what I've seen happening is once you deliver a big win at a health systems level in one geographic location, other leaders sit up and notice and they say, I want that. I want to do what they're doing. And it moves a little bit quicker. So I just wanted to, you know, talk about that short-term, long-term balance in this process.
Thank you, Dr. Nadal.
Bien, también tratando de resumir todas las consultas, quería empezar con esto del recurso humano y por ahí los...
Human resources and the different power levels within the health system, which make it easy to apply or not some reform. And here I like to say that we need to distinguish different levels. We have the political level, yes, of course, they have to show commitment to be able to take steps in these SDR policies, everything that's needed to change the health system. But at the same time, we need to begin to work and take a look at the construction at other levels to be convinced about the commitment from the different decision makers in their management, even at micro and micro levels. So they all need to be convinced about these change processes and they need to become part of the co-creation. And this is something that's one of the objectives of the studies, the preliminary study in Mendoza, but it's to call them to be a part of it, to partake in change. That's how I understand that beyond this political decision making powers, that's how these health decisions may be sustainable throughout time. In addition to the fact that we should have the flexibility to be able to adapt to needs and changes. Now about the information systems, based on the local experience in Mendoza, which is undergoing preliminary studies and we are trying to collect proof, I think that if we do this with a wide view, with a comprehensive view, with everyone's participation, we can extrapolate it to other experiences in other territories based on the understanding from what we heard. The experiences in the health system are pretty similar in our countries. And now about the importance of the information systems to be able to build evidence and to be able to make sure that this translates into networks. In the specific case of the Republic of Argentina, it can be extrapolated or replicated in other provinces. I believe that we are facing a big challenge. It's a pathway that we need to face. It's a long way. I'm talking about the province of Mendoza. We're transforming our digital means, and that's key. Here we need, from any angle, we need to generate information systems, assistance information systems. We're working on that. Also, management information systems, hospital management information systems, so that we can dashboards or decision panels where we can see indicators that show the present situation and also that it help us forecast the future. So we have the information systems available today and we use those. They can all be enhanced, of course, but we have the need to make sure that we see this transformation and we can articulate within the province even the information systems, because in very many cases, since there hasn't been previous governance with that same view, they have developed other operation systems that do not gather information. They're not based on international standards. Even us within our own province, within our institutions, sometimes it's complicated. It's hard to have quality data collection. So that's something that we still need to do in Argentina. We need to have legal framework. We need to do development, further development and implement it. But of course, we understand that this is not overnight. We need to take time and we need to try to anticipate future complications based on the little information we have. But it's again, information collection or data collection is a challenge we face in our country, especially in a province. They need to develop interoperable systems and quality data to be able to identify and continue with the care associated to this model of our health model that we have. I mean, we know who you are, we know your name, we know what your disease, but we need to find the most vulnerable people, those who need it the most, and be able to take care of them on time, properly throughout the whole health system. That's the trajectory we're building. Thank you.
Finally, Keith, I hope you're still there. Just some last final words from yourself. Oh, Keith, you're just on mute.
Sorry for that, Vicky. So I'll take 3 points. The first one is if you combine the power issue, the political change over the accountability, I would like to talk about leadership and governance. I think the key thing for me and our lesson that we've learned in our area, 26 years of ongoing reform and now a path for the next 10 years. We did that in our province subnationally with 9 different political dispensations. Not once did the trajectory change with the change of political. So I believe leadership is quite central. I believe the strength of governance, and for the administrators to take a central path of being guided by a people-centered healthcare system and taking a very strong stance. And political allies, any politician comes in our system, actually very gladly accept the trajectory we're on. And we say to the political person, we're going to make you look good. This is your political manifesto. But as officials, we're very strong in that conversation. The second issue is about collaborative approaches. And our experience has been where you can take the power issue out of the place, because power normally stymies collaboration. So where we can say, look, guys, let's just get together. We want the same thing. For instance, for us, it is really just about setting a few set of simple rules. A unique identifier is exactly that. A unique identifier at the country level is to give you one unique identifier approach for the whole country because it assists. Even you can do it for a region because you can do it across countries in the area because people will be seeking healthcare across country borders. So unique identifier, we just need to have a set of rules. The second big thing is interoperability. That means people can develop systems, but there are some basic rules for interoperability that systems talk to one another. And if you take that, but the biggest thing is actually humility and saying, finding the common ground to influence people to work to a common purpose. And that can be done between us. We're doing it with fellow provinces, next door neighbors. We're doing it with the national department. We started to do it even in the African region with other countries as well. And then the last thing is about the people-centered healthcare system when it comes to health workforce. There is no health system without health workforce. You must design what you do around your health force. You need to make your health workforce co-design and co-own the process. Without them, there is no health system reform. Thank you.
Great. Thank you all, and thanks for a really rich discussion. I think we're about to round up our session. So I'm going to invite Dr. Jeffrey Smith from the Bill and Melinda Gates Foundation just to give us a few closing remarks as we close the session. Yeah.
A round of applause for this panel. And it's always good to run out of time because it means that the conversation has been active and really focused. I just want to share 3 reflections as we close here. The first is skepticism. The second is natural transition. And the third is about doing the right things, not just doing things right. The first is we should be skeptical about service delivery redesign. We're having some discussions about SDR with the government of Pakistan, with the government of one province, KP, Khyber Pakhtunkhwa. And the minister said to me, so what you're asking me to do is change things that you've been telling me for the last 30 years and do something different. In a sense, we are. In a sense, we're asking people to not just spread care everywhere, but to try to think about what care is most necessary and where do we provide that. And so we've got to evaluate this. We need to look very critically at this because we do a lot of things in global health that are not tested. And we have the opportunity to do something here and really test it well and determine whether or not it has impact. The second point is about natural transition. I think we saw from the colleagues from Mendoza and from the colleagues from Western Cape that this process, and from India, this process has been happening over time. It wasn't because of a paper in the Lancet. It wasn't because we stood up here or gathered in a ballroom and made this decision. This has been happening for quite some time. And I like something that Margaret said to me a number of months ago. Health systems are living things. We can either let them move naturally or we can help direct them towards better outcomes. And I think we have the ability to be more intentional about what health systems do and not just let them go willy-nilly, go widely in different directions. So I think we have, when there's a concept that WHO uses that is being revised right now. It used to be called the obstetric transition, but it's being revised to be more inclusive, to be the maternal and newborn transition. And that's recognizing that countries are at different phases of how they respond to their health, their population's health needs. I spent many years working in Afghanistan. When I arrived in Afghanistan in 2002, maternal mortality was 1,600. The things you do in that situation when maternal mortality is the highest in the world, those are different than things that you do when maternal mortality is 150 and you're trying to get it to 100 or to 70. So we have to be cognizant, not to abandon previous strategies, but to add new strategies. Service delivery redesign is a new strategy. It doesn't replace the other strategies. It adds things on. Believe me, as an obstetrician, I know that the cases of maternal and newborn mortality are just getting more difficult. They become more and more complex, not less complex. The easy cases of mortality can be dealt with quickly. Now we're down to amniotic fluid embolism and renal failure in preeclampsia and preterm birth at 28 weeks. You can't solve those problems in a health center. So as we transition towards more complex scenarios, we need more complex and responsive systems. And that for me brings me to the third point, which is we have to do things right. We have to do the right things, not just do things right. We can work extremely hard at improving delivery services in PHC primary healthcare centers that do 5 births a month. You can spend a lot of energy improving that health center, but if it only does 5 births a month, it's not designed for birth. Its intention is not designed for the acute care that is managing birth. Imagine, put yourself in a situation of a midwife who's managing a primary health center. She's got a whole bunch of people. Women are there for antenatal care. Children are there for immunization. Maybe some adult men have come for diabetes screening. And then a pregnant woman comes in, laboring. What does she do? Stops everything else, tells all those people to wait, and goes and gives her attention to one person. That person deserves the attention, but now that we've disrupted the entire primary healthcare system. So we shouldn't combine preventative care and supportive care with acute care. If you try and put acute, do we tell men who have chest pain, well, first thing you should do is go to the primary health center to see if you're having a heart attack. They'll evaluate you, you'll wait in line for, no, if someone's having an acute medical emergency or an acute medical condition, they have to go to the right level of care. So I think as we think about clinical systems, we can't think about doing everything everywhere. The natural progression is to develop some expertise and some specialization. So I think service delivery redesign is recognizing that. it makes perfect sense to screen for diabetes and do management of diabetes and hypertension at the primary healthcare level. I'm not convinced anymore that it makes perfect sense to do births at the primary healthcare level. We have to think about births at or near a center that has the ability to provide comprehensive care, immediate care. So I'll leave you with those three thoughts. One question that Rodolfo had was, how are we getting people to talk to each other? And this meeting has been very important. I'm really excited to hear some of the questions that were asked. But Kojo has put a lot of energy into establishing a community of practice. And I think we need to start thinking about formal structured processes for sharing what we're learning in different parts of the world. It's wonderful to come to Bogota and to exchange ideas. We can't do that every day. So looking for ways and structured platforms for sharing what we're learning, either at the national level, at the regional level, or at the global level, we're putting those pieces in place. And I think that's a real opportunity that is before us. So thank you for your attendance. Thank you for your really strong and inquisitive questions, because we have to think carefully about the steps that we take in order to, when we're redesigning a system, we have to be very intentional and very smart about it. So your inputs have been critical. Your ideas you need to continue to share, but first you need to go enjoy some lunch. So thank you very much for attending. The lunch is going to be just out. We go out the room, down the hall to the right, into the corridor, and go to the left. It's in the Nariño room, Nariño. Great, thank you.